Hello, everybody. It's my pleasure to welcome you to this symposium. This is the yearly symposium of the Swiss NASH Foundation. My name is Jean-François Dufour. I'm the chairman of the board of this foundation. We have this afternoon very interesting programs with international recognized speakers. This year was really an interesting year for NASH, as you will hear, in terms of definition of the disease, in terms of treatments. We have positive results with interesting drugs, which will probably move ahead. We are supported for this program by Madrigal and AstraZeneca. We are very thankful for them. We'll also provide the prize, the Max Meyer Prize, to a recipient which has been selected. We are very thankful to Dr. Meyer for supporting the foundation over the years and this prize. We'll also have a presentation of the Patient Association. So we'll have several presentations. We'll keep on time. I will be the last one. And this is really my great pleasure to introduce Professor Sven Francque, head of department at the University of Antwerp. Francque published hundreds of papers on fatty liver disease. He's also the leading author on the lanifibranor trial, and he has been also instrumental in the new nomenclature of the disease. So it's really a great pleasure to have you with us today, Sven, and without overdue, I will give you the floor. Thank you very much.
Thank you very much, Jean-François, not only for the kind introduction, but first of all for the invitation to be part of your program today. I'm trying to put my slides on. Okay, I think this is okay for you. Okay, thank you. So these are my disclosures. Now, as has been said by Jean-François, one of the things we achieved this year is a revision of the nomenclature of what was formerly called non-alcoholic fatty liver disease. And then, of course, it's important to go back to the reason why we have done that. And so if you remember, non-alcoholic fatty liver disease is, of course, the presence of fatty liver or steatosis in the absence of alcohol consumption above a certain threshold, and also in the absence of other known causes of steatosis. We used to call them secondary causes of steatosis, like the use of steatogenic drugs, for example. So that definition is a negative definition. It tells you that you have liver steatosis, but it tells you also what the cause is not, but it doesn't tell you positively what the real cause of the disease is. So the name of the disease and the definition of the disease does not include any indication of the cause. Now, we know, not perfectly, but we have some insights in the cause of what we formerly called NAFLD. We know that it develops in the context of overweight and obesity, insulin resistance, dyslipidemia. So it's often quoted as being the hepatic manifestation of the metabolic syndrome. So we know that, but that's not reflected in the name nor in the definition of this disease. Another problem is that the patient population that we design with NAFLD is very heterogeneous. Another term that was reflecting that heterogeneity was also lean NAFLD or lean NASH, so NAFLD NASH in people of normal body weight defined by BMI, so that reflects how heterogeneous that population is. And another major issue with the old nomenclature is that it is exclusionary. So as you see on the left-hand side again, you have to exclude other causes of steatosis, and that's not reflective of reality. We know in our daily practice that many patients will combine different risk factors for steatosis, and the most frequent combination is, of course, people that are living with overweight or obesity and also drink too much alcohol. And then that is a group that we are or we didn't have a proper system to diagnose them and to study them. So there were a lot of issues with the old nomenclature. Now, the issues with the old nomenclature fine, but that does not mean that an alternative was so evident to find. Now, a few years ago, there was a proposal to replace the name NAFLD by MAFLD, metabolic dysfunction associated fatty liver disease. And you see here the criteria that were proposed in the first publication of this new or alternative nomenclature. And so the definition was that you needed a diagnosis, of course, of steatosis, and there are different modalities to make that diagnosis. And then if you have overweight or living with overweight or obesity or with type 2 diabetes, if you have one of those, let's say, major criteria, you qualify for the diagnosis of MAFLD. If you're not living with overweight, obesity, and there is no type 2 diabetes, then you need at least 2 out of those, what you could call minor criteria, to get the same diagnosis. So this was a very valuable proposal. It really made sense, although there were some issues also with this proposal. First of all, and one of the most important ones, was that in this whole proposal, there's nothing specifically about alcohol. And that led to quite a lot of confusion also in the research that was generated with this definition, that many of those so-called MAFLD populations constituted, at least in part, of people that were also consuming considerable amounts of alcohol, but that were not considered separately. They were all classified under the MAFLD umbrella. And there were even in vitro models of MAFLD that exposed hepatocytes to the classical model of exposure to palmitic acid, for example, and other fatty acids, and on top of that, alcohol. Of course, that's not what we understand with the term metabolic. So it created that confusion. And also there was the concern about still stigma associated with the term fatty, which is not across all cultures around the world the case, but in many countries, also in Europe, I think, fatty is, for the people living with it, associated with stigma. And there was also some concern about the consensus methodology of this proposal, but it was a valuable proposal, and it really showed the community that we really needed to do something about the classification and the nomenclature of this disease. And so that's why, under the leadership of 3 major scientific societies, so the European Association for the Study of the Liver, the American Association for the Study of the Liver Disease, and also the Latin American Association, they started a process, a true consensus process, to revisit the nomenclature for fatty liver disease. And meanwhile, we announced the results of that lengthy process at the Liver Congress in Vienna, the EASL Liver Congress in Vienna. And meanwhile, it has also been published in the 3 journals of 3 societies that I just named. But it was not just the 3 societies, it was supported by many other societies, as you will see in a moment. And you see here also on this slide, you see on the bottom several logos of different associations that have been very supportive of the process, endorsed the process, but also endorsed the outcome of the process. And you see that we also have a global representation of people in the Delphi panel that constituted of more than 150 people, and they come from all over the globe. So I think this is really a multinational, international, worldwide consensus process that has been built by these societies. Just briefly, how did we proceed? So the 3 associations have asked 2 chairs, Maru Rinella and Phil Newsom, to be the chairs of the process. And then there were 6 group leads, and I happen to be one of those 6. And then we had the Delphi panel, as I said, that constituted of more than 150 people, coming from all different areas of expertise that are involved in this problem. It's not just hepatologists, experts in non-alcoholic fatty liver disease. We also had hepatologists of other areas of expertise, most notably from the alcohol alcohol-related disease specialists, endocrinologists, general practitioners, pediatricians were also important partners, and last but not least, also patient organization and patients advocate were all part of the Delphi panel and participated in different rounds. We had different rounds of the Delphi panel. As you can see here, we had 2 rounds, and then we had an in-person meeting, which was very important to really exchange ideas and to better understand really some of the questions put forward in such a Delphi round, because you can put forward the question, but it's not always so easy to understand if you answer yes or no to a question, what all the consequences of that answer can be. So that in-person meeting was really important to exchange that amongst the members of the Delphi panel, and there were then some successive rounds to, in the end, come to the global consensus that, as I said, was presented in June, just before the summer this year. Now, a first conclusion of that whole process was that we wouldn't achieve the goals if we wouldn't go for an overarching term. And that is mainly because what I said in the beginning, the exclusionary nature of NAFLD is a problem, because in real practice, many patients will combine different risk factors for steatosis. And so that's the main reason why we came up with the concept of having an overarching term that, as an umbrella term, encompasses all the different causes of fatty liver disease. And it was also because of mainly the stigma associated with the term non-alcoholic and fatty that we changed from fatty liver disease to steatotic liver disease, which is a more scientific term, yes, but also a more neutral term. So, but the real aim of that overarching term is to say, okay, we start from a feature, like in granulomatous hepatitis, you have the feature of granulomas, and then you have a whole long list of differential diagnoses. The concept is here a little bit the same. You have the feature of steatosis, which is the entry point of the diagnosis, and then you have to consider different causes of steatosis that you all need to verify before you make the etiological underlying diagnosis of the feature that you are observing. So that's the idea behind the overarching term. And that is what I said before. It's important here to stress that introducing that concept of the umbrella term, it does not mean that we reclassify or we change the definition of underlying diseases. I mean, Wilson's disease, for example, it's still Wilson's disease. There's nothing that has changed regarding the definition of Wilson's disease. The only thing we say here is, and we all know that steatosis, steatohepatitis can be an important feature of Wilson's disease. So under the umbrella of steatotic liver disease, you need to consider the possibility of Wilson's disease. That's all what is meant by this approach. As I said, it was not fatty liver disease, but steatotic liver disease, and that is mainly because of the stigma that is associated with the term fatty, at least in some countries and in some cultures. It's not throughout all cultures, but it's in a substantial amount of people an issue. So that's why we opted for the more neutral scientific term of steatotic liver disease. As you can see, then under the term steatotic liver disease, we still have to look then for the replacement term for NAFLD, because we are still not having a replacement term at this stage for the non-alcoholic fatty liver disease. And then there were several proposals made. They were ranked in the Delphi rounds. We came up with 3 top proposals selected by the Delphi panel, and then it was a committee that needed to really make the final choice out of these 3 acronyms and also come up with an according definition, because it's not just the name of the disease, there's also a definition that comes with it. What is important is that we realize that under the umbrella, of course, the 2 main causes of steatotic liver disease are alcohol, and then everything that is related to overweight, obesity, insulin resistance, again, the metabolic syndrome. Besides those two main etiologies, you have, of course, other etiologies that are less frequent, but nevertheless, of course, important to identify. So one of the consequences of this umbrella approach is if you have all these different etiologies, you will also have patients in whom you make a diagnosis of steatosis, but in whom you cannot find any of these causes. So you create a new category, which is liver steatosis, steatotic liver disease of unknown origin, or what is called cryptogenic steatotic liver disease. That's the consequence of having those different causes with their specific definitions. So we create a new category. Another important point is that this system with the umbrella allows you also to combine different etiologies, as you will see. Now, what then with non-alcoholic fatty liver disease? The disease that we all know is associated with those metabolic risk factors, but we don't have it in the name. How are we going to name that disease? And as I said, there were many different proposals that came up at the beginning of the process. They were ranked. There was a top 3 choice. And then out of those 3 top choices, finally, there was one term that was chosen. Now, what was clear at a certain time point is that metabolic needed to be in the name because it's really a central aspect of the pathophysiology of the disease. So that's why the metabolic term came into the name of the disease, which was also previously in the MAFOD population proposal that I discussed at the beginning of my talk. Another important point is that still almost 100% felt that we needed to keep a distinction between steatosis and steatohepatitis. Steatohepatitis being liver steatosis with inflammation and damage to the liver tissue. In essence, that concept has not changed. So NAFLD, isolated steatosis, NASH, still we keep that concept of isolated steatosis and steatohepatitis in the same context. So that framework has not changed. As I said, we had 3 possibilities in the end, all with metabolic in it, and then a consensus about the final name of the replacement term for NAFLD, and it's hence metabolic dysfunction associated steatotic liver disease. Steatotic liver disease, again, because that's the overarching term, and metabolic because that is really indicating where the cause of this disease is lying, and we keep the concept of associated steatohepatitis, but it's of course not NASH, it's MASH. As I said, it's an umbrella term, so you have different other etiologies under the umbrella. Of course, alcohol, again, is an important cause of steatotic liver disease. You have all those other etiologies that can exist. You have the category of patients that do not have one of these causes, which is then the category of the cryptogenic. And then if you have all those single etiologies, another consequence of this concept of umbrella term is that you can easily combine all these different single etiologies. So a patient with steatotic liver disease can have 1, 2, 3, 4 causes of steatosis at the same time. Now, the most important combination is obviously the combination of metabolic risk factors and the consumption of alcohol. And that's why the consensus came up with the proposal to have a specific name for that category, which is the MET-ALD. If the consumption of alcohol is above the thresholds that are mentioned here, we estimate that alcohol is really the dominant driver of the disease and that it's mainly alcohol-related liver disease, although I think you can discuss it because even in these patients, if there are metabolic drivers of disease, they may have an impact on disease progression. If it's below these thresholds, then of course you have the MESLD. If it's in between, it's the MET-ALD category. And as I said, you can have all other kinds of combinations also. That was not in the final diagram in the publication, but of course you should consider it. The combination of metabolic factors and alcohol is of course not the only combination that you can have. You can have all kinds of combinations, and the advantage of this system is that you can properly name it and easily put a label on the diagnosis in these patients. The definition of, because it's not just a name, it's also a definition, what is metabolic dysfunction? You see here the criteria. You need to have 1 out of 5 criteria related to BMI, related to glucose regulation, blood pressure, plasma triglycerides, and cholesterol. As you can see, these are the criteria that also define the metabolic syndrome. They are ethnicity adjusted and also age adjusted, because you have here the criteria that apply for pediatric patients. So this definition is really in line with the definition of the metabolic syndrome. There was a discussion in the panel if we should go for just one criterion or a combination of at least 2 criteria, or a major and minor criteria, as was the case in the MEFOD proposal. The final consensus was that 1 criterion is enough, and you will see that in practice that seems also to work. Again, as I said, we do not change the concept of isolated steatosis versus steatohepatitis. That has not changed. And the MET-ALD category, I also discussed already with you what the definition is and also what the concept is behind that category. How to approach it in practice? The first step is, of course, that you have a diagnosis of steatosis, and there are different modalities. We did not specify what modality should be used to define steatotic liver disease. That was not the aim of the nomenclature process. And then the question is, does the patient meet any of the cardiometabolic criteria? If yes, then of course you need to question whether there are other causes of steatosis. If not, then it's MESLD. If it's yes, it means that there is at least dual etiology, and it can be alcohol or something else. If there are no metabolic criteria, then of course you need also to consider all the other causes of steatosis. So it's quite straightforward. And if you don't find any cause, then it's cryptogenic steatotic liver disease. So I think it's quite straightforward. Points to discuss for sure about the interaction between alcohol and metabolic risk factors. I think one of the advantages of this system is that now it will force everybody to have systematically a look into this, and always, if you have patients, if you examine the effect of alcohol, you should also look into the metabolic risk factors, and vice versa. If you are specifically interested in the metabolic risk factors, you should also study alcohol as a factor. So I think this will help us to generate data that give us a better insight about the positive, additive, or even synergistic effect between alcohol and metabolic risk factors, because we have very few data on that. There are a few data out there, but it's really very limited. And in most of the studies, these patients, especially from the metabolic point of view, these patients are excluded. And so this system should really foster research to better understand the combination of those 2 risk factors. In the meantime, we have been seeing already many letters and small publications about this new nomenclature and what it means in practice. This is one example where from the UK Biobank, they looked into patients with an MRI and a diagnosis of steatosis based on MRI, which is one of the gold standards to diagnose steatosis. You see 40,000 people. Prevalence of steatosis, so steatotic liver disease, was about 28%. And of those patients, about 11,000 patients, the vast majority, 85%, had MESLD. Pure ALD was only 1%. The MET-ALD category was about 10%, and then the other ones were cryptogenic or with missing data. So giving you a better idea about the repartition and the different etiologies across the spectrum. Also important is to understand in another study where they used CAP for the diagnosis. It's not the gold standard, so it's a little bit more questionable in terms of accuracy of the diagnosis. But again, a large population from the ENHANCE study populations, so the cohort 2017-2020. Also, as you can see in the final sample, more than 3,000 patients, a slightly higher, numerically higher prevalence of steatotic liver disease. And again, if you then look into the causes of steatotic liver disease in these patients, the vast majority is MASLD. There is also the proportion of alcohol-related, the combo MET-ALD, and also interesting, the combination with viral disease. So again, illustrating here how with this system, you can properly diagnose the combination, the combined presence of different causes of steatosis in a single patient. Also interesting is that in this system, they compared the different definitions. So they compared the definition of NAFLD, MASLD, and the older MAFLD. And as you can see, especially regarding MASLD and NAFLD, there is a slight difference, which is mainly the cryptogenic category. But for the rest, also interesting if you compare MAFLD to MASLD. Again, the definition of the metabolic criteria was different, but in the end, you see that in clinical practice, it doesn't make much of a difference. There are a few people that are discordant in the two systems, but not so many. Implications, finally, for research and clinical practice. Again, I think that we will now better characterize all factors in a given patient that contribute to steatotic liver disease, so we can better understand and study the synergistic effect, especially between metabolic risk factors and alcohol. And it will also help us to really think about treating all these factors at the same time, probably not all with the same priority, but at least we will think about all these different potential causes of steatosis and install a proper treatment and not focus just on one cause, but also pay some attention to the other causes. Does it have an impact on drug development? It's also a matter of discussion. I don't think so. As I showed you, the old NAFLD and the new MASLD population, they largely overlap, especially those in clinical trials are largely overlapping. So the data generated so far will still be valid. It does not invalidate all the research that we have been doing so far. And also for future trials, it will not have that much of an impact because you always define your in- and exclusion criteria. And so if you have, if you want to study it in one specific disease, metabolic, you will continue to exclude patients that consume too much alcohol. The only difference is now, and we will see that emerging quite rapidly, is that we will now study also patients that combine metabolic risk factors and alcohol consumption, and we will also do clinical trials for these patients. And in the trials we have been running so far, these patients have always been excluded. So that is a step forward. And with this, I come to the end of my presentation. I think that the new system provides a positive name and diagnosis, is not stigmatizing. It helps us to look at all the different causes. There is a large overlap, so it will not invalidate our old research. It better identifies, or it better names those in whom we don't find the cause. We call them now cryptogenic, instead of classifying them as we did in the past within the NAFLD group. So we keep those now separated. And I think it will mainly help us to improve the clinical care of these patients and also the design of the studies. And it's not carved in stone. So if research brings up issues and we can still improve this system in the future, I think we will do, and we need to do so. But for the time being, I hope it's a major step forward in both clinical care and research in this area. Thank you. I will probably stop sharing.
Thank you very much, Sven, for this presentation, and congratulations for being part of this process, which is really structuring in a positive way the landscape. You addressed the point in terms of clinical trials, which has been done what we know already about the disease, which was NASH, can be probably, for most of it, be translated under the new umbrella. Probably there's one aspect which could be easier to move, is to free the field from the necessity to have a liver biopsy and to go on NITs to define the steatohepatitis. What do you think of that?
For sure, especially if we want to run trials in large populations, which is for sure needed if we want to study clinical outcomes in this very slowly evolving disease. We need to have tools to diagnose the disease without liver biopsy. We are not there yet, especially not in terms of identifying steatohepatitis, and also not in assessing treatment response. We know that some parameters change with treatment, but what magnitude of change is clinically meaningful or not, there's still a lot of research to do there. But I think, to me, the liver biopsy is still a very rich source of information, and it's clearly something that in research and early development is important in trying also to understand the potential of some treatments. But for the large phase 3 trials especially, we for sure need other tools. And I think we made already a lot of progress, but we're not there yet.
We have a question in the chat from pediatric Thomas Züger, who is asking, what is the cutoff that we will use for the cap, if you use the cap for the steatotic part of the definition?
Well, what we intentionally did not do in this nomenclature process was giving strict definitions on how to define steatosis. That was not part of the task that this process was assigned to. So I think this is something that is part of the clinical practice guidelines of the different societies, and might also evolve in the future, because like with transaminases, we see a shift to lower and lower thresholds to make the diagnosis. Now for CAP, whether it's 247 or something in around that figure is probably a right cutoff. The accuracy of CAP for the diagnosis of steatosis versus no steatosis seems to be rather acceptable. For a more precise quantification, probably it's not the ideal tool. I think, especially for it might be good for epidemiological purposes, but I think in an individual patient, I would do a second test to confirm the diagnosis of steatosis.
And we have another question on cryptogenic SLD. So you exclude the most obvious reasons, and then you label cryptogenic, but you would have to do in these patients to do a genetic test, or how you see the place of some polymorphism impacting on the disease?
For the time being, I think if it's really cryptogenic, but it then means that you have thoroughly explored potential metabolic risk factors. So it's absolutely not the same as lean NAFLD, which was a horrible term in my opinion. So we really need, even in people of normal weight, check for metabolic risk factors. But if you really don't find anything, I think for research purposes, that genetic testing in the future will still be conducted in order to try to better understand that category of patients. For the clinical practice, it doesn't have a lot of impact for the time being, because what are you looking for? Or you have to do a GWAS, and one day, if it's affordable, it will probably come into clinical practice, but then we still need to know how to work with whatever we can find. So I think for research purposes, to better understand that category of patients, it's for sure a tool that we need. In clinical practice, routine clinical practice, I think, yeah, it's looking for a needle in a haystack, and you only test what you test, except if you do a GWAS. I don't think it's necessary. But if you have indications for more advanced liver disease, then genetic testing will for sure be one of the issues you have to look for. But you will search for mitochondriopathies and other rare diseases in lipid metabolism, for example. But again, yeah, you cannot just pick out one test, because it's thousands and thousands of pathways that can be altered. So.
Well, Sven, thank you very much for this presentation, for being here with us today, and wish you can continue to stay with us this afternoon. Otherwise, thank you very much for being here.
You're welcome. It was a pleasure. Thank you.
And we'll move to our next presentation, which fits well after this nomenclature definition. We'll talk about MET-ALD, how to tackle it. It's my special pleasure to introduce Dr. Naomi Lange, with whom I work in Bern. She's a really terrific person, a fantastic thinker, a rising star, being now based in Mayo Clinic, I think now. But thank you very much, Naomi, for joining, and also to tackle this important aspect of MET-ALD. It's yours, Naomi.
Thank you so much, Jean-François, for having me and for this kind introduction. I will share my slides. Do you see the slides well, and do you hear me well? Wonderful. So I think we've already heard quite a bit about the challenges associated with MET-ALD, and I will elaborate on this a bit in my talk. Touching on different aspects of this new condition. First, a quick introduction. As you mentioned, Jean-François, I work as a research fellow in hepatology at Inselspital in Bern under Professor Berzigotti. More recently, I have also worked as a resident in addiction medicine in a smaller clinic close to Bern. Right now, I am, as you said, in the Mayo Clinic in Rochester as a visiting research fellow or research collaborator at Malhi Lab. And I've been a board member of the Swiss NASH Foundation since 2020. And regarding this talk, I have nothing to disclose. So now a graph that you have seen if you've been in this meeting since the beginning. We do see the overarching term. We have the metabolic dysfunction associated steatotic liver disease, as we know that does exclude significant or relevant alcohol consumption. And now, what is new and I think very exciting is the MET-ALD. So metabolic liver disease and a relevant alcohol intake. How do we define relevant alcohol intake? Well, it is defined according to gender. So we have 20 grams per day for females and 30 grams per day for males. And experience as a physician, I think this captures what we see in clinical practice very well, because our patients are on a spectrum ranging from moderate alcohol consumption or increased but not very high alcohol consumption to very high levels of alcohol consumption. Now, to get the diagnosis of MET-ALD, patients also need to confirm with the definition of MASLD, which is 5% of steatosis. So, as was raised in the questions, this can be either a CAP value according probably to the NAFLD, EASL guidelines or American guidelines. But they also need to have at least one metabolic comorbidity, which I think, as we see in clinical practice, is the case for a lot of our patients. And then they need to have alcohol consumption. And I think this graphic by the group in Denmark covers it very well, because I feel like Met-ALD is a lot more complex than what this previous graphic leads us to believe. There's the spectrum ranging from greener to redder. This only captures alcohol consumption. So when we start here at the bottom, that's basically what we've seen before. But then we also have in these patients different genetic risk factors that, of course, we're not regularly testing for, so we might not know who is a fast progressor, slow progressor. And a lot of these genetic modifications or risk factors have been found to be true both for NAFLD and for alcohol-related liver disease. And then when we look at the metabolic comorbidities, working in a project with my colleagues from diabetology at the Inselspital Bern, I think what is striking is that diabetes is such a variable condition. So we have varying degrees of insulin resistance. Glycemic control might vary between one patient to the other. And I think we have seen, for example, in a paper by a French group, that we can split diabetic patients into risk strata, and some will progress very slowly and some progress rapidly. So just the presence of diabetes per se does not necessarily tell me a lot about the risk of my patient. The next factor that is often present as a metabolic comorbidity is obesity. And here the same principle holds true, because varying adipose tissue distribution might carry a different risk for progression of liver disease. And as we see here, when we look at non-invasive tests, we need to take all this into consideration. So we might have a FibroScan value of, let's say, 10 kilopascal, and in a group that consumes high levels of alcohol, that might be associated with a different risk as compared to patients who consume much less. So I think what this highlights beautifully is how complex this is, and how as clinicians we really need to dig into phenotyping our patients to be very accurate in the assessment of our patients. Now, the prevalence of Met-ALD, and I think we've heard a bit about this in the previous talk, so I will not spend a lot of time on it. But just to give you an overview, this study looked at prevalence of steatotic liver disease using the NHANES data from 2017 to 2020. And what they found was prevalence of MESLD of around 32%, and 2.5 to 3% of these patients, or of the patients assessed, would be classified as having Met-ALD. Pure ALD was only around 1%, as was other combination etiologies, so medication associated steatotic liver disease in combination, or viral hepatitis and steatotic liver disease. Now, why do we still need to look very closely at this population? And I think what this is about is we need to find out, or we see that these patients are at a higher risk to progress to significant liver disease, or at least that's what's being debated in the literature. So when we see in patients here the moderate alcohol use, Met-ALD versus MESLD, in this study wasn't actually not associated with a higher risk. However, when we look at higher liver stiffness values, it seemed to shift a bit more, so even more advanced fibrosis. Met-ALD was closer to being associated with higher liver stiffness values. And there was a meta-analysis that has been done looking at the association between moderate alcohol consumption and more significant liver disease in several cross-sectional studies and cohort studies. Now, looking at the cross-sectional studies that look at odds ratio, we see it is not clearly showing us that there is a higher risk with moderate alcohol consumption to have more advanced liver disease. In the two studies reporting hazard ratios, we do see that alcohol seems to be associated with a higher risk of significant liver disease. And not shown here, but when the authors looked at only cohort studies, they did also see a pooled odds ratio of 1.56 that was significant, as well as with the hazard ratio. So it is being discussed, but I think at the moment the data are not 100% clear in the data that we have. But I think, as was mentioned in the previous talk, there is a large data gap regarding alcohol consumption. And so why do we have this data gap? Well, before we go into the problem of self-reported alcohol consumption, I would like to point out this study that assessed whether providers systematically asked for alcohol consumption. This was an international survey going out to hepatologists, but then also to endocrinologists and primary care providers. And providers were asked what they would do if they find NAFLD, so steatosis, incidentally in a patient. And only around 57% stated that they would investigate the presence of alcohol consumption. So we don't know, because the wording of the question is a bit tricky, since it already says NAFLD. Maybe that was misleading to the participants. However, I think we need to be aware that it is also our responsibility as physicians to be very clear and adamant to assess alcohol consumption in our patients and be willing to talk about that with our patients. And this is a study that beautifully highlights why it is so important to really ask and to maybe also, not distrust the patients, of course, but be a bit just strategically investigate alcohol consumption, even in patients that we initially believe to not drink a significant amount of alcohol. This study was performed in Austria, and they had around 180 consecutive patients where they systematically employed tests for alcohol consumption, so the Odyssey, several unspecific blood markers, urine, ETG, and hair ETG. So what they found was that among the patients that were classified as NAFLD, around 28.6% were found to actually do have moderate to excessive alcohol consumption, according to the panel of screening tests. And how they classified true positives in the study was that the patient had to admit to drinking alcohol regularly after being confronted or being talked to about the positive test results. And then using this true positive as a reference standard, they did find that hair ETG had an excellent test performance ability to diagnose moderate to excessive alcohol consumption. But also the Odyssey, which is very, very easy to implement. It is associated with no costs, had a decent performance. So I think we need to really strategically use these and be sure that we really investigate. What biomarkers for alcohol use are there? So we have indirect biomarkers that reflect toxic effects of alcohol on organs and tissues or body chemistry. And while they are useful in clinical practice to maybe give us an idea, I think all of us know that they are very unspecific. So more direct products of ethanol metabolism can also be used as systematic screening tests, however, are associated, of course, with higher resource use. I think PEth has gotten a lot of attention recently and is being increasingly used, at least in our centers. Now, I would like to point out to you one thing that maybe we would like to see in the future, because we know alcohol is not a one-time assessment; it is a time-varying covariate. So we would, I think, all like to see the alcohol consumption of our patients over a course of time, and maybe these transdermal alcohol sensors in the future will be how we can do this. And in this study, that was also a meta-analysis, the authors looked at the correlation between blood and breath alcohol levels and the transdermal alcohol sensors' ability to measure alcohol concentration. And they found a decent correlation. However, the wrist device, which you see here on the bottom, a more modern device, may be preferable with a higher correlation compared to the ankle measurement. They did have a long average lag time of about 90 minutes, so between blood alcohol or breath alcohol and then the transdermal measurement. However, I guess if we're using it for more epidemiological assessment over time, the lag time for us is not such a relevant factor. And most of the studies were performed under controlled circumstances, so I think it needs to this needs to be proven in practice more. And of course, it also is based on the willingness of our patients to wear this monitoring device, which may be a challenge, but we would see. So the pathophysiology of MET-ALD, as you can see, very complex. So one factor, we have the genetic factors as mentioned, and the unhealthy lifestyle influencing, of course, the gut being associated with dysbiosis, and then also affecting, of course, adipose tissue, being associated with inflammation, its function of adipose tissue, all of this leading to insulin resistance, lipid accumulation, and de novo lipogenesis. And what alcohol does is basically influence all of these systems. So I think this graphic beautifully shows us that the effects of alcohol and metabolic syndrome in MET-ALD patients will be very hard to distinguish. And again, I think we need to be really accurate in phenotyping, which will probably be key to decode some of these overlapping and synergistic, as well as very characteristic individual effects of the substances. Now, one study I would like to show you is an animal model that was developed for the overlap between alcohol use and metabolic syndrome. So this was the dual model named after the dual etiology methodology, which was a previous nomenclature. And what the authors did is they put ethanol in sweetened drinking water that was sweetened with glucose, and they ended up using a 10% alcohol concentration. And as you can appreciate here, after 23 weeks, looking at the dual mouse model, they did develop hepatomegaly, and from the color of the liver, it appears to be severe liver steatosis. Also, this is shown here in the graphs. The liver weight was higher compared to the other diets, and to the Western diet and to the pure alcohol model, as well as a higher liver to body ratio. Now, they also did develop advanced steatosis. The Western diet, you can see here, had some steatosis, but it seems to be much more pronounced in the HE staining here in the dual model. And this is also what the authors found when they looked at the steatosis score. So then the next thing that they investigated was, of course, the inflammation. And you can appreciate here when staining for markers of liver inflammation that there seems to be a pronounced pattern in the dual model, which is also shown here, looking at the percent of CD45 positive cells and the TNF alpha mRNA expression. It is somewhat closer to the Western diet as compared to the steatosis, but it is definitely higher than the ethanol group alone. So the combination metabolic factors and ethanol seems to be leading to high inflammation. And now what about fibrosis? And here the authors show the histological assessment of their liver sites. And as we can appreciate here, the fibrosis area that developed under the dual model was significantly higher as compared to the other animal models. And they also did investigate this with different markers, collagen 1, and yeah, found similar collaborating results of this. So they state that their dual model also leads to prominent hepatic fibrosis. Now, how do we tackle MET-ALD in a therapeutic sense? And this here shows you all the different treatment targets that we currently have for MASLD, and you will hear a lot more about them in the upcoming talks. I would just highlight a few of them that I think might be interesting and important in the MET-ALD condition. And one of them I think that we need to have a closer look at is GLP-1, and you will hear all about the effect of GLP-1 dual agonist and dual agonist in the next talk. But what has been found in animal studies is that GLP-1 receptor stimulation decreased alcohol intake in several mouse models. And this has been something that has been discussed for a longer time. And now, of course, as we start using GLP-1s in our patients with MASH or MET-ALD, this is something that has garnered a lot of attention. And this is a preprint that was recently published. So, you know, take this maybe with a grain of salt. It's not verified yet. But what the authors did is they did send out questionnaires to patients in groups on Reddit and other social media channels focusing on GLP-1. And they asked patients whether they feel like they did have less of a desire to consume alcohol after starting GLP-1 treatment. And 21% of those who responded reported ceasing drinking altogether after intake of GLP-1s, and around 90% report a reduction. And you can see here the self-reported desire to consume alcohol in dark before semaglutide and in lighter blue after semaglutide. And you can appreciate the shift of this curve towards consuming less alcohol. I think it's exciting, and I think there's a lot of groups working on this, but we will see hopefully more solid data on this in the future. But so GLP-1 and MET-ALD is definitely a treatment to watch. Now, as was mentioned in the previous talk, the problem that we have is that a lot of patients or MET-ALD patients were excluded in the studies concerning MASLD therapy. So one trial I think that is worth noting is the GALA-RIF trial from the group in Denmark, which was designed in alcohol-related liver disease. However, when you look at the baseline characteristics, the majority of the patients that were included in the study would actually now be classified as MET-ALD. So I think the mean alcohol consumption was around 50 grams. The participants were predominantly male. So with 50 grams, we're in the higher spectrum of MET-ALD, but we're still in ALD territory, and many of the patients or participants had at least one metabolic comorbidity. So in this investigator-initiated randomized trial, they were targeting the gut-liver axis, which is also an interesting target for both conditions, as we have seen alcohol influences intestinal permeability, high-fat Western diet changes, the composition of the gut microbiome, etc. So the authors used rifaximin alpha in these biopsy-proven alcohol-related liver disease patients. And what they did see is that there was not a lot of significant differences in these dual in this dual biopsy study. However, they did see less of a progression of fibrosis in the rifaximin alpha group. And here we can see over the time course that markers for inflammatory activity in the liver, so ALT, did decrease over the course of time in the rifaximin alpha group, and it did stay somewhat lower during most of the trial duration. What is also really interesting to see, and I think highlights again that we need to really assess alcohol consumption regularly, not just at one time point, is the changes of daily alcohol consumption in these patients. Of course, self-reported, but I think you can see very well that there seems to be a wide variation, fluctuation in the placebo group as well as in the treatment group. So this might have influenced the trial results, because it seems like the treatment group did consume more alcohol on average in this. So very important in and of itself, this graphic, I think. Another treatment for MASLD that has garnered a lot of attention, especially since publication of the Braves RCT, is bariatric surgery for MASLD. So here, the authors show that patients that were put in the group to receive a Roux-en-Y gastric bypass or a sleeve gastrectomy had a much higher percentage of steatohepatitis resolution without worsening of fibrosis compared to the patients who were receiving lifestyle modification. When you look at the improvement of at least one stage of liver fibrosis, the treatment or the treatment effects of Roux-en-Y gastric bypass and sleeve gastrectomy were not as as prominent compared to the lifestyle modification, which is something we of course know from randomized controlled trials in MASLD therapy. So while this is giving us very good data to use this treatment in our MASLD population, I would like to point out that in MET-ALD patients, we might need to be more careful. This is a study that showed regular alcohol consumption here in blue, and symptoms of alcohol use disorder in patients after undergoing metabolic bariatric surgery. And as you can see, there was a tendency to increase alcohol consumption and report of AUD symptoms coming from the more psychiatric side to approach alcohol or substance use. I think motivational interviewing is a very promising technique. So this is a client-centered directive communication technique, and it's aimed to improve the intrinsic motivation for change in our patients. And what you would do is build a partnership with the patients, show acceptance to them, but also build their acceptance for their current state, find their intrinsic motivation for change, and really see what sparks this motivation to change in them, rather than posing it on them, like telling them, you know, this is bad for you, your health is going to suffer, rather finding what motivates them. And then last but not least, really show them compassion, because change in behavior is not easy. And I think compassion in this setting really does go a very long way. And here in this paper, they highlighted beautifully at what stages we can add which, you know, motivation enhancement treatment in the setting of alcohol-related liver disease. So brief interventions using motivational interviewing might be good to use in the setting of alcoholic hepatitis, because this might be a pivotal experience for the patient and spark their motivation to change. But also, of course, while they're on the transplant waiting list, we need to keep doing these interventions. So I think something that as providers we can work on to build these techniques. Now, to sum it all up, how to tackle MET-ALD. So I think correct diagnosis and classification is key. And for this, I think we need to use biomarkers strategically and also a thorough clinical assessment. We need to rigorously phenotype our MET-ALD population so we can optimize risk stratification, but also our treatment strategies. We need to find an accurate and feasible mouse model for MET-ALD. Rifaximin alpha might warrant further exploration in the MET-ALD population. And two therapies that are established for MASLD that I think we need to take a closer look at in MET-ALD are GLP-1s, regarding their effect on the desire to consume alcohol, and also bariatric metabolic surgery for risk of an addiction shift. And I think that training and motivational interviewing might be a helpful tool, because we can target alcohol use, obesity, diabetes control, so several conditions in these patients at the same time. Thank you to the University of Bern for providing the grant for me to come here to Rochester, and of course to the Swiss Liver Foundation for supporting me. And I would like to thank you for your attention.
Thank you, Naomi. This was a beautiful presentation. You really dealt with all the different aspects which need to be touched in this. Wonderful, really. We have a question to you.
Yes.
What do you suggest doing to get more solid data and reliable results building on the self-report studies?
Yeah, that is a very good question. I think patient-provider trust is a very big deal, because once I have a trustful relationship with my patient and they know that I will not shame them for reporting alcohol use, I think they will be more likely to be open about their alcohol consumption. And I know in clinics where we might see a patient just once or twice, it is hard to establish this relationship. Maybe digital tools like an app where, you know, maybe they can have face-to-face interactions with a dedicated nurse on an app that will ask them about their alcohol consumption regularly. I think this for me would maybe be an interesting try. Another very interesting approach is to collect the data indirectly. So for example, collect shopping data or data on the use of social media, etc., where we can maybe kind of extrapolate alcohol consumption. So AI and big data might be another way to get that information without direct self-reporting.
Interesting. I would be careful now when I go shopping. Another question, where do you place here patients' organization?
Oh, patients' organizations are pivotal in tackling MET-ALD, because as we've already heard in the previous talk, stigma plays a huge role around especially alcohol-related liver disease or also MET-ALD. And I think patient organizations can help, you know, bridge that gap between the provider, the public, the patients, to really encourage patients to come forward and share their stories, and for us to really show empathy and be there for our patients. And there was a beautiful talk on the Schweizer Lebertag that was held last week. And if you have not seen it, I really urge you to please go watch a patient of Dr. Susana Rodriguez report on her alcohol-related liver disease and liver transplantation. I think it's phenomenal, and this is doing so much good for all patients affected by liver disease.
Well, we'll probably hear more about that with Mrs. Karina Bobsin, who will present the patient organization in a
Wonderful.
moment. And we have a patient from Manuel to you, our next speaker. What is the place of PEth? How do you use it in your clinic?
Mm-hmm. So PEth in our clinic is, in the liver clinic, is used mainly in the pre-transplant setting, but also in the diagnostic stages. So I think we've become a bit more wide with the indication for using PEth testing, of course, because it's available to us. And I think the advantage of PEth is that according to the data that we have now, it shows a longer duration of regular alcohol intake. So we use it to kind of see if there's maybe a relevant long-term alcohol consumption in these patients. And then, of course, in the pre-transplant setting, we need to address this and then initiate appropriate treatment for AUD in these patients. In the addiction medicine setting, we use breath alcohol testing and urine ETG. And in this setting, we openly communicate that we will use it regularly. And I think a lot of our patients are actually very grateful for this because they report that it does support their sobriety. So I think we need to get away from the belief that we're punishing patients by testing them, but we need to communicate that hiding alcohol consumption is a symptom of alcohol use disorder. And by testing for it, it's like we're testing for your HbA1c in diabetes. So we're testing for a symptom of a condition that you have. We're not, not punishing you or not trying to catch you or something, but we're trying to see something that might be present in your condition. That's how I think we should maybe approach it in our clinics and communicate to our patients.
Well,
Great
thank
question.
you, Naomi. We can feel the passion about it. That's fantastic.
Sorry.
I'm sure you'll
Yeah.
find your way here for the future. No, thank you very much, and also for
Thank
the
you so
great
much.
presentation. And it's really a great pleasure to introduce a good friend, Professor Manuel Romero-Gomez from Sevilla, who is the head of department. Manuel published regularly over the years on different topics, on genetics in liver diseases, on imaging, and now he's a prominent KOL on fatty liver. And it's really a great pleasure to have you here, Manuel, presenting on treating NASH with weight-losing drugs, dual agonists. Thank you.
Okay, I'm sorry, I was talking along. Thank you. Thank you very much, Jean-François, for inviting me. It's a pity not to be in Bern, but as you know, the agenda is very busy in the last month of the year. And thank you also for asking me to talk about, to debate about the potential usefulness of dual, some triple agonists, GLP-1, GIP, glucagon. This is my disclosures, and as you know, is a paradigm has been involved demonstrating that weight loss could be a major target in the management of patients with muscle D. If we promote using lifestyle intervention at 10% loss of body weight, we can improve or promote NASH resolution in 90% of the patient, fibrosis reduction around 80%, and improvement of steatosis. But the main limitation of this intervention is just 10% of our cohort reach 10% body weight loss. That means we can use as a major target. If we can reach this percentage, we can accurate or define response in our patient. But it's not very easy to translate that the different manners we have to promote weight loss, the lifestyle intervention using drugs like the GLP-1 or the dual agonist, or using bariatric surgery or endoscopy metabolic. This weight loss could be translated to an improvement of steatohepatitis, and perhaps we can really promote fibrosis regression. However, we have no enough data to support a change in the overall natural history of the disease. That means that when we are taking care of our patient, in a patient with muscle D, we implement a lifestyle intervention, doing physical activity, mainly 150 minutes per week, so doing aerobic or resistant moderate exercise, together with a diet that should be a Mediterranean diet designed according to the nutritional geometry to reach the much higher comfortability, adherence, and the effect of this diet. After that, if we promote weight loss and ALT normalization, perhaps we can demonstrate that our patients are responders, and we know exactly what the patient needs, and we are keeping this lifestyle intervention for long term. However, in patients that they don't reach enough weight loss or keep ALT alterated, we can classify as non-responders, and we need to try to reach these goals by the use of drugs or doing a bariatric surgery. At this time, we have dual and triple agonists. The triple agonist is just because we have very, very recent data that it could be nice just to speculate, because we have data on GLP-1 agonists and dual agonists. In the dual agonists, we can mix a GIP plus a GLP-1 agonist. That is the case of tirzepatide that has been used in several trials, and GLP-1 plus glucagon receptor agonist. It seems the idea that the GIP plus GLP-1 is a little more anti-diabetic, that could modify a little more the glycemic index and the alteration in the metabolism of the carbohydrate. But the glucagon receptor, together the GLP-1, could be a little more specific for liver disease. At least efinopegdutide, pemvidutide, and cotadutide has been used in the management of muscle D, and recently we have data for a triple agonist promoting a very, very impressive weight loss. These drugs, when we are putting together, we can reach many organs by many different mechanisms of action. And for example, GLP-1 could promote a decrease in food intake and decrease body weight. This is a major effect, but also could impact on the adipose tissue, decline adipokine secretion, and increasing the visceral adiposity storage, and the white adiposity storage. Could decline bone resorption. That means we can prevent bone diseases. It's a debate if we need to use agonists or antagonists of the GIP, and we have data supporting both possibilities. GLP-1 receptor, as you know, increase insulin secretion and promote decline in the glucose level due to the glucagon effect, and finally, the glucagon could modify the phosphorylation and achieving quite interesting endpoint like decreasing glycogen or increasing glucogenogenesis, that if we reduce glycogen from the liver, we can improve, we can decrease lipogenesis, steatosis, inflammation, and fibrosis. Trying to design a heat map is just a summary of all these mechanisms of action. We can find here the different organs: the brain, the adipose tissue, the pancreas, the heart, the gastric, the bone, the muscle, and the liver, with all these so large number of mechanisms of action in red when the drug promote an increase and improvement, in green when decrease food intake, decrease appetite, in blue with no effect. And you can see here the three different agonists, the different action, and curiously we can imagine a world in which we are using just one drug with three different compounds and many different targets. That means it could be quite similar to a combination therapy. You know, we can address many targets at the same time. As you know, the well-known New England Journal in 2020 by Phil Newsom demonstrate how semaglutide 0.4 milligrams per day demonstrate an ability to promote an improvement in the transaminase, promote NASH resolution in 60% of the patient, much higher than in the placebo arm, but no difference in the fibrosis regression. That means GLP-1 agonist, semaglutide, used every day in injection, could promote NASH resolution, but not promote fibrosis regression. This is the main reason by which at least three different dual therapy has been developed. The pemvidutide, that is characterized to is 1 is the same amount of glucagon versus GLP-1. Cotadutide is 5 times more GLP-1 than glucagon, and that means that cotadutide is quite similar to semaglutide because it's the much higher activity is GLP-1, and efinopegdutide that has a 1:1 proportion. That means 2 GLP-1 by 1 glucagon. This taking account this balance, the GLP-1 and glucagon, we can highlight the key effect and summarizing: decreasing food intake, a slow gastric emptying, and increased insulin secretion, decreasing glucagon secretion. This is the main effect that promote an improvement in this patient. When you analyze what can we find on the literature, this is the 4 main trials combining GLP-1 and glucagon using the Boehringer drug, the pemvidutide, the efinopegdutide, and combining GLP-1 plus GIP in the tirzepatide drug. It's just quite a slide showing how retatrutide, triple agonist, GLP-1, GIP, and glucagon, could promote in the dose of the 8 or 12 milligrams per week, how more than 5% weight loss was found in more than 90%, and for example, weight loss more than 10% in 75%, more than 15% in 60%, and more than 20% in 40% of the patient. That means it's a very impressive effect. But I'm not absolutely convinced that promoting so important weight loss, we can solve and we can restore the liver disease. This is a summary of the trials in a fantastic review by Phil Newsom that should be released next month in Journal of Hepatology, and this is the main data that I'm showing you in this presentation. Was Amalia Gastaldelli in Lancet Diabetes and Endocrinology demonstrate how tirzepatide is a very useful drug removing fat in the liver, and tirzepatide 10 milligrams and 15 milligrams altogether versus the control, the insulin degludec. They promote liver fat infiltration, liver fat concentration decline of minus 8.09 versus 3.38. That was clearly significant. When you compare 10 to 15 milligrams, seems to be a little more effective in tirzepatide 10 milligrams minus 47%. It's decreasing by a half the infiltration of the liver. When you use PDFF, you can demonstrate in the image studies how the decline in the fat in the liver is very impressive, around 47% in the 10 milligrams arm, and this decline was clearly related with the decline in the transaminase and also in the bad volume. Cotadutide, as we said, is a 5-to-1, was also able to promote a reduction in the fat infiltration. The 300 micrograms promote a decline in the AST. It's a modest decline, around 10%. It's not very, very impressive, but it's improving. In the ALT is around 15%, and also changing slightly FIB4 and NFS. Analyzing the change in the glucose metabolism, the decline in the glycate was quite similar between the three arms of cotadutide versus liraglutide, and superior to placebo. That's the idea that no very important difference between this 5-to-1 cotadutide versus GLP-1 agonist. However, when we analyze the change in the body weight, the comparison versus placebo is much higher, but the difference was 0.09, was minus 5% versus minus 3.3. Is a modest reduction in the body weight with a slightly significant difference, but it's not a very impressive difference as we can see in other drugs. The phenopeptide was also tested in muscle D, and a paper released this summer in Journal of Hepatology. Is the combination of GLP-1 plus glucagon receptor, and using this formula to increasing the dose until 10 milligrams of a phenopeptide versus 1 milligram of semaglutide. It was just 1 milligram of semaglutide because it was the dose that was approved at the time of the design of this study for the treatment of diabetes. And in these 145 patients, 72 receiving a phenopeptide, 73 semaglutide with no baseline difference. You can see how the decline in the fat infiltration in the liver was very impressive, more than 70% in the patient receiving a phenopeptide versus 40% in the semaglutide group, reaching a statistically significant difference. The percent 70% of the population receiving a phenopeptide reached more than 70% decline in the fat in the liver. Even normalization of fat in the liver, lower than 5%, was possible in 2/3 of the patient receiving a phenopeptide versus 17% in the SEMA arm. And you can see here also the decline in the body weight that was a little much higher in the phenopeptide arm, minus 8.5% versus minus 7.1%. Finally, if we divide according the percentage of body weight reduction, patient with a phenopeptide in more than 10% body weight was found in 86. The decline of fat in the liver was more than 85% in patients losing more than 10%. But in patients losing less than 10%, you can see how was losing 75% of the fat in the liver. That means it's a potent effect promoting weight loss improvement in the biochemical profile of the liver, ALT decline in both arms, both in semaglutide and phenopeptide. The pheno could be a little faster, but at the end of the day was the same, and the HT2, but also the systemic effect of the phenopeptide decreasing systolic blood pressure and diastolic blood pressure was also quite interesting and could add benefit to this therapy. The tolerance adverse event was a little more common in patients with a phenopeptide, and just one patient with a serious adverse event in each arm, and 5.6% for patients discontinued the drug due to an adverse event. The majority of them were related with the gastrointestinal area, abdominal distension, abdominal pain, upper abdominal pain, constipation, diarrhea, dyspepsia, flatulencia, and gastroesophageal reflux. That means this type of drugs promoting body weight, apart this slowing of the gastric emptying was associated with more symptomatic effect. The pemvidutide, the 1-to-1 study, this is a 1AB in which with the same design, 3 different doses, 1.2, 1.8, 2.4, and analyzing liver fat content by magnetic resonance PDFF, proton density fat fraction. The absolute decline in the fatty liver was minus 15% in pemvidutide 1.8, much higher than pemvidutide 2.4, completely different from the placebo. And the percentage, the relative percentage was around 70%. Also, a very impressive, very profound decline in the fat infiltration in the liver, around 70%, that has been related, as you know, with the potential histological response. But this aspect we need to demonstrate in clinical trials in which we can have baseline liver biopsy followed by a second liver biopsy. This is a summary that we are addressing a highly complex disease. The appearance of muscle D, MASH, and fibrosis depends on the genes, on the gut-liver axis, on the lipid and the glucose metabolisms, the mitochondrial dysfunction, ammonia production, and ureagenesis, together with the oxidative stress. Perhaps we need to better stratify our patient. When we are promoting a weight loss, we can improve metabolic, the majority of the metabolic disorder. For sure, we cannot change the genetics, or we can modify the microbiome, but we are not overlapping completely. If we are losing weight, we are improving the liver. Approximately 60, 70, 2/3 of the patient could improve. But some patients, this 1/3, 20% of the patient, could suffer from a different alteration that require a specific approach. That means when we are using dual, we are using 2 molecules able to address many targets, but not addressing all these targets. We need more data, what is happening in the fibrosis in the liver, using non-invasive as MRE or liver biopsy, but also we need to analyze how can these drugs promoting weight loss restore the different altered mechanisms. But at the end of the day, we need to select patients that could not be cured using this type of approach, or at least this patient that require more drugs, more actions to address the rest of the target that has been excluded using these drugs. And finally, just to summarize that the weight loss is a major target in muscle MASH, that lifestyle intervention, drugs, and bariatric endoscopy surgery could reach this goal. Weight loss seems to impact differentially on liver damage according to the procedure. That means we can, using lifestyle intervention, have much higher improvement in steatohepatitis and fibrosis, but we need to demonstrate what is happening with these drugs. Using bariatric surgery, we have data supporting that the effect is also very impressive. Semaglutide promotes weight loss and MASH resolution, but not fibrosis regression. And in some case, we are not sure what is happening using dual agonists, GLP-1 and glucagon, because they promote larger weight loss and fat removal in the liver, but no impact on fibrosis has been reported yet. We need to wait for these phase 3 clinical trials demonstrating how these drugs could impact on the liver health. The amount of weight loss did not correlate directly with the liver improvement. It's curious that it depends not just in the final amount. I don't know if losing 20, 25, 30% of body weight could improve the liver much better than losing 10 or 15%. And finally, precision medicine and innovative trial design, together with the combination of therapy, might help to improve the overall efficacy and efficiency of treatment for NAFLD. And this is my team in Seville, in Virgen del Rocío University Hospital and the Institute of Biomedicine of Seville. And thank you very much for your attention. And I'm ready for a debate with these very innovative and fascinating new drugs. Thank you.
Thank you, Manuel. It's very amazing to see how the field is moving from, monoagonists to dual and triple agonists, different kinds of dual agonists as you presented. So we do have some questions. I will read them to you. How is the weight loss associated with GLP-1 agonists linked to decreased hepatic inflammation in patients with MASH?
It's quite. We developed in the trial in which we demonstrate the 10% rules, in which a patient losing more than 10% achieve a NASH resolution in 90% of the patient. We developed a NASH resolution calculator. It was a formula that including ALT normalization plus the percentage of body weight loss, together with some comorbidities or baseline variable like the presence of diabetes, etc. And using this formula that was published in hepatology, we can anticipate patients that could reach NASH resolution. When Phil Nilsson, using this same calculator, analyzed in the Lange study, that was a study using liraglutide, and demonstrate that this formula works in the same manner. That means if we are losing more than 10% in the body weight, perhaps we can reach this NASH resolution in the majority of the patient. And I think this is the key point supporting the data that Phil reported in the New England Journal of Medicine, that 60% of the patient achieve NASH resolution due to the body weight. But we need to keep in mind all time that together with body weight, with body weight reduction, and the semaglutide or GLP-1 agonist, we need to keep in mind that the physical activity is also a very, very important aspect to improve inflammation in the liver. And if our patient is increasing activity, the physical activity, they could improve the liver in spite not reaching so large body weight loss.
I have a second question here. In the context of MASH, how do the effects of glucagon receptor activation complement the beneficial outcomes of GLP-1 receptor agonism?
It's a fascinating question. Thank you. Because as you know, when we are studying the glucagon at the beginning many years ago, we know that glucagon was related to portal hypertension, even some mechanism of action of some drugs were related to the ability to decline glucagon. I was surprised when people started using glucagon receptor agonists in this combination therapy. But at the end of the day, we have two data. One, in the animal models, demonstrate that it could counterbalance the effect of GLP-1 agonists and could have a little more effect on the liver. This is the big difference between tirzepatide and efinopegdutide or cotadutide, because the GIP is a little more glucogenic or related to the glucose, but the glucagon could modify the metabolism of the carbohydrate, promoting, for example, a clear improvement in the liver, which is the key mechanism of action. Doing that is not clear at this time. I has been discussing for a long time about that. We need more data. We have data from the clinical and the preclinical experiment, but when we are using this type of umbrella, when I'm showing you the heat map, not showing all the different mechanisms that the drugs they are promoting, and each of these one, you can find many actions that they are very difficult to decipher. In summary, I cannot say you why glucagon receptor agonist has a positive effect in together with GLP-1 in this patient, but I'm feeling it has.
Well, thank you. Following on these questions, we do have some patients not responding to GLP-1, which they are interesting in it. This is interesting in itself. Do you think these patients may be rescued or respond to dual agonists?
I don't know. For example, cotadutide, the 80% of the drug is GLP-1. That means I think no. Pemvidutide is 1-to-1. Perhaps we need to check. It depends on the main mechanism, the main reason by which the patient is non-responder. If due to intolerance or due to a lack of efficiency. I don't know, but if a patient is not responder to GLP-1 agonists, I think we can try to use this dual therapy because apparently we are adding a different part of the molecule or a different molecule, and we can anticipate a little more weight loss, and it's a very impressive the impact on the liver. The dual could decline fat 60, 70, 75% of the fat in the liver decline versus 40 or 45% using just semaglutide. A potential more beneficial effect and one more mechanism of action will invite us to use in obese people, non-responders to semaglutide.
Well, thank you very much, really, Manuel. I know you're a very busy schedule and to take the time to present us all this data. Thank you very much, really. And
thank you. A great pleasure, and thank you for inviting me, and a great pleasure to discuss about that, because we need to check from hepatology to biochemistry to endocrinology, etc. It's very fun. Yeah. It's absolutely fun. Thank you very much.
So now we take a break, a short break. We take a 5-minute break. We'll begin at 15:50, and we'll have the presentation of the patient association. Then we'll have Receptor and FGF21. So 5-minute break. Welcome back, everybody, to this symposium. This is the annual symposium at the Swiss NASH Foundation. I am Professor Jean-François Dufour. I'm the chairman of the board. We already had very interesting presentations on different treatment on the aspect of alcohol, Now we'll deal with other aspects. I remind you that at the end you will be able to get your credits. They will be online. You will be able to download them. I would like also really to thank our sponsors who allowed us to have this meeting today, Madrigal and AstraZeneca. Now we'll have a presentation on the Swiss Patient Association that will be in German and that will be given by Mrs. Karina Bobsin. Karina.
Guten Nachmittag. Von ganzem Herzen möchte ich mich für die Einladung von Professor Jean-François Dufour von heute bedanken, für das virtuelle Symposium 2023, A Pivotal Year for NASH. Als ehrenamtliche Präsidentin und Gründerin vom Schweizer Leberpatientenverein, Swiss HEPA und Schweizer Lebertag ist es mir eine große Ehre und Freude, Ihnen unsere Präsentation vorstellen zu dürfen. Swiss HEPA ist der erste Schweizer Verein, der Patientinnen und Patienten mit allen Lebererkrankungen unterstützt. Am 22.11.2017 habe ich Swiss HEPA gegründet mit den Zielen, Bewusstsein für die Diversität von Lebererkrankungen zu schaffen, den Erfahrungsaustausch rund um die Leber zu fördern und Betroffene aktiv zu unterstützen. Ich bin die Mutter einer 24-jährigen Patientin, bei der 2015 plötzlich ein aggressives, komplexes Overlap-Syndrom mit schweren Komplikationen und vielen Krankheitsaufenthalten gegründet hat. Wir haben am eigenen Leib erfahren, wie niederschmetternd und schockierend eine solche Diagnose sein kann. Nicht nur für die Patienten selber, sondern auch für die liebende Familie. Das Schwierigste für mich zu dieser Zeit war die Ungewissheit und die vielen persönlichen Fragen, die mir niemand beantworten konnte zu dieser Zeit. Das war der Grund, warum ich mich entschlossen habe, diesen Leberpatientenverein zu gründen, um gemeinsam Antworten zu finden und betroffene Patienten und ihre Familien zu unterstützen. Was bewegt Swiss HEPA? Nun, was bewirken und bewegen wir? Wenn laut Schätzungen in der Schweiz bis zu 3 Millionen Menschen an einer Lebererkrankung leben und davon nur etwa 15% diagnostiziert und in ärztlicher Behandlung sind, dann sollte Prävention und Awareness uns alle etwas angehen. Auch wenn die Leber eines der wichtigsten Organe des Menschen ist, wird immer noch zu wenig Fokus auf die Leber und Lebererkrankungen gelegt. Die Zahlen von chronischen und immer jüngeren Leberpatientinnen und Patienten steigen stetig. Die Fettlebererkrankung ist unaufhaltsam auf dem Vormarsch. 2030 soll es schätzungsweise doppelt so viele Leberkrebspatienten und Patientinnen geben. Sind das nicht erschreckende Prognosen? Darum ist es Swiss HEPA auch mit ihren knappen personellen wie finanziellen Ressourcen weiter ein wichtiges Ziel, bestmöglich zu informieren auf unseren Plattformen www.swisshepa.org und www.lebertag.ch sowie auf unseren Social-Media-Kanälen wollen wir weiter informieren. Es ist Swiss HEPA ein Bestreben, unsere Informationen und Angebote in den 3 Landessprachen Deutsch, Französisch und Italienisch sowie auch in Englisch weiter anzubieten, um noch mehr Betroffene zu unterstützen. Auf unserem YouTube-Kanal sind bereits über 127 Videos mit Referaten von Spezialisten und Spezialistinnen und Interviews von Patientinnen und Patienten in verschiedenen Sprachen online. Auch die Vorträge vom 1. und Schweizer Lebertag sind bereits aufgeschaltet und auf beiden Plattformen und YouTube zu finden. Gerne mache ich Sie jetzt auf unsere verschiedenen Angebote aufmerksam. Darunter gehören die Patientenhotline. Diese Patientenhotline ist extrem wichtig. Hier kann man täglich einfach spontan telefonieren. Man kann als Angehöriger oder Patient Fragen stellen. Man kann, wenn man nicht mehr weiter weiß, einfach da sein füreinander, sich gegenseitig zuhören und einen Erstkontakt knüpfen. Auch bei Auch bei einer Einzelberatung können wir mit mehr Zeit uns dem Patienten widmen und sie vertiefter unterstützen. Dabei können wir besprechen, wie man sich den Alltag als Betroffenen allenfalls erleichtern kann und seine Lebensqualität verbessern. Wir können Patientinnen und Patienten stärken und sie auf dem Weg des Selbstmanagements begleiten und unterstützen. Vielen Betroffenen hilft es zu wissen, dass man mit der Situation der Erkrankung nicht alleine ist. Daher ist der geschützte Austausch in den Selbsthilfegruppen zu Meetings mit anderen so wichtig und hilfreich. Und gerade damit man keine zusätzliche Energie aufwenden muss, um sich irgendwo zu treffen, kann man sich einfach per Zoom zuschalten und kommunizieren. Auf der Homepage kann man sich für die Meetings neu in allen 4 Sprachen anmelden. Neu ist Frau Isabel Baes für die Romandie und Frau Claudia Rizzi im Tessin zuständig, sowie in Englisch weiter Frau Fabienne O'Hara und ich für den deutschen Bereich. Manchmal hilft es genau dieser persönliche Kontakt, wo man sich in einem Zweiergespräch vertieft unterhalten kann und den anderen direkt in die Augen schaut. Daher bieten wir auch vierteljährlich Selbsthilfegruppentreffen in Zürich an und ab nächstem Jahr neu auch in Chubasco und in Lausanne. Bei einem herrlichen Sommerplausch hat es uns allen, wie Sie sehen, viel Spaß gemacht mit Minigolfen, sich austauschen und viel lachen. Seit 2022 bieten wir aber auch eine digitale Sprechstunde an. Die ist auf Deutsch mit Professor Andreas Krämer. Hier geht es darum, allgemeine medizinische Fragen zur Leber zu stellen und mehr zu verstehen. Es ist immer wieder sehr interessant und man kann hilfreiche Empfehlungen heraushören. Neu auch mit Frau PD Dr. Benedetta Terzel-Rori Beretta Piccoli auf Italienisch und ab 2024 neu mit Frau PD Dr. Montserrat Fraga Christinette in Französisch. Das ist wunderbar toll, weil diese Ärzte, sie stellen die Leber ins Zentrum für unsere Patienten und Angehörigen. Natürlich meine Frage an Sie, neu, spezifisch für NASH, könnten wir die Fettleber auch ins Zentrum stellen. Vielleicht möchte sich jemand dazu melden und einmal im halben Jahr eine Sprechstunde auch bei uns direkt mit Patienten zu starten. Es würde uns sehr freuen. Unsere SwissHepa Community App ermöglicht einen direkten und geschützten Kontakt für Betroffene. Sie wird auch gut genutzt. Ganz wichtig sind natürlich auch die Veranstaltungen, wie die letzte Woche der 2. Schweizer Lebertag. Hier geht es darum, viele Informationen zu erlangen, sich mit anderen Betroffenen auszutauschen zu können, sowie sich auch mit Ärzteschaft und Industrie zu vernetzen. Auch die breite Öffentlichkeit soll mehr mit dem Tabuthema Leber in Kontakt kommen, um Lebererkrankungen Schritt für Schritt zu entstigmatisieren. Dazu möchte ich Ihnen die Folie zum 2. Schweizer Lebertag zeigen, die wir mit sehr viel Erfolg, wir hatten wieder über 120 Teilnehmer vor Ort und knapp 100 Teilnehmer online, auch aus der Deutschland, aus Österreich und aus Liechtenstein. Sie waren alle sehr willkommen. Wir hatten wieder ein tolles Programm unter der Moderationsleitung von Professor Dr. Med Annalisa Perzigotti. Wir hatten ein total tolles Programm mit fantastischen Referentinnen und Referenten, die sich wirklich extrem engagierten mit Herz und Leidenschaft. Und darunter jetzt auch noch kurz als Beispiel Leberkrankheit und Alkohol mit Dr. Med Susanne Gomez-Rodriguez, die eine wunderbare Präsentation geboten hat. Und wir hatten auch das große Glück, bei vielen Referenten einen Patientendialog führen zu können. Und das war eine ganz geglückte mit einer Patientin mit dem Namen Corinna. Und sie hat ihre ganz herzergreifende Geschichte über ihr Alkoholproblem, wie sie zur Fettleber kam, bis sie eine Transplantation bekommen hat. Es war wirklich eine ergreifende persönliche Geschichte und so ein offener Dialog mit ihrer Ärztin von Susanna Gomez-Rodriguez. Es war wirklich eine fantastische Darbietung, die niemand missen möchte. Und das möchte ich auch zeigen, dass Swiss HEPA wirklich mit seinen Unterstützungsangeboten und Informationen eine wichtige Schnittstelle für Leberpatientinnen und Patienten sowie Ärzteschaft und Industrie ist. Wir dienen mit unseren Aktivitäten als Bindeglied und solide Brücke für einen kontinuierlichen Netzwerkausbau. Was sind unsere gemeinsamen Ziele und Wege und Ziele? Die steigenden Zahlen zeigen, wir müssen mit stabilerer Vernetzung, Aufklärung und Informationsfluss den Vorsorgerahmen verbessern. Wir können mit Patientenstärkung das Selbstmanagement unterstützen. Mit Lancierung von Awareness-Kampagnen und Umfragen bauen wir mehr Verständnis für die Diversität von Lebererkrankungen auf. Und mit dem Schweizer Lebertag können wir öffentlich aktiv die Leber ins Zentrum setzen und so verstärkt auf die Politik und die Medien eingehen. Der 3. Schweizer Lebertag findet am 21.11.24. im Schuf in Lausanne statt, in Zusammenarbeit mit Frau PD Dr. Musra Fraga Christinet. Natürlich geht das nur mit großartiger Unterstützung und mit Sponsorengeldern. Ohne Sie alle wäre das gar nicht machbar. Und gerne erlaube ich mir zum Schluss einen höflichen und wichtigen Kommentar. Swiss HEPA ist eine gemeinnützige Organisation und Verein und alle Vereinsmitglieder arbeiten ehrenamtlich. Ich als Präsidentin und Geschäftsführerin arbeite durchschnittlich etwa 60 Stunden pro Woche. Mein ganzes Engagement und mein Tun ist ehrenamtlich. Darum sind wir auf jede wertvolle Unterstützung angewiesen, um die Angebote von Swiss HEPA, wie zum Beispiel der Schweizer Lebertag, weiter allen Betroffenen und Interessierten gratis zur Verfügung stellen zu können. Darum zählt jeder Beitrag oder Spende doppelt für uns. Natürlich nicht vergessen und gerne lade ich Sie ein, am 21.11.24 wird in Lausanne die Patientenveranstaltung auf Französisch vor Ort angeboten. Bei genügend Unterstützung wollen wir hybrid das erste Mal versuchen, eine Simultanübersetzung in Französisch und Deutsch online anzubieten. Wir freuen uns schon sehr, diese Mehrsprachigkeit in der Schweiz besser nutzen zu dürfen. Und ganz zum Schluss, ganz herzlichen Dank für Ihre Aufmerksamkeit und ich freue mich auf Ihre Fragen.
Vielen herzlichen Dank, Gaila, really for this presentation. Du hast das wunderschön gemacht, wie immer. Und ich weiß nicht, wo du findest so viel Energie, um alles das zu machen. Das ist absolut top. Sehr beeindruckend. Sehr, sehr. Und wir brauchen einen Verein von Leberpatienten in der Schweiz. Ja. Sehr wichtig. Ja. So, es gibt einige Fragen. Sie sind auf Englisch geschrieben. Darf ich das auf Englisch sagen?
Ja.
To what extent does raising political and public awareness aim to emphasize and promote the importance of prevention?
Ich kann das.
Ja, du kannst probably auch lesen.
Kannst du es mir das auf Deutsch vielleicht ein bisschen noch klar machen?
Ja, Sie möchten wissen, was diese Awareness-Kampagnen, das du organisiert, sie werden auch einen Effekt auf die Prävention von den Krankheiten haben.
Ja, also ich glaube einfach, wir sind ja noch ein junger Verein. Also wir sind ja erst seit 4 Jahren wirklich online. Wir sind noch ganz jung. Wir sind auch ein kleiner Verein, aber nur schon, dass zum Beispiel wir hatten von der Politik, vom Gesundheitswesen hatten wir Flavia Wasserfallen für die Begrüßungsrede und sie ist ja auch Swiss HEPA Ambassadorin. Und sie ist ja ganz eng verbunden mit Anträgen auch vom BAG, vom Bund. Also wir erhoffen uns durch kleine Vorstöße bei Behörden, bei Politik, dass wir wirklich spezifischer und aktiver mit Lebererkrankungen und mit spezifischen Erkrankungen etwas erreichen können und mit dem Schweizer Lebertag natürlich in die Öffentlichkeit gehen können.
Ja. Und es gibt eine zweite Frage, aber das ist ein bisschen im gleichen Bereich. Aber geht das, wie du willst eigentlich Daten erheben in diesen Kampagnen, das du machst?
Also ich mache natürlich Umfragen. Also wir haben jetzt zum Beispiel vom Schweizer Lebertag haben wir letztes Jahr Umfragen gestartet und wir sind auf die Bedürfnisse der Patienten eingegangen und wir hatten zum Beispiel über 70% Antworten. Praktisch jede Antwort war mit persönlichen Kommentaren bespickt. Also die meisten wirklich nur positiv. Also wenn man von dem 5,5 hatten wir alles zwischen 5,5 und 5,4. Auch dieses Jahr hatten wir so viele Kommentare und ich glaube, dass wir so Stück für Stück, Schritt für Schritt ganz viel erreichen können. Und wenn wir sehen für die kleine Schweiz, wie auch online unsere Veranstaltung der Schweizer Lebertag angeschaut wird. Also zum Beispiel, es war ein Symposium von der Deutschen Leberhilfe vor 3 Wochen mit etwa 150 Teilnehmern. Wir hatten über 100 Teilnehmer. Dann würde ich meinen, für unsere kleine Organisation, und uns gibt es ja erst 5 Jahre, können wir einfach stolz sein, was wir erreicht haben. Und mir geht es gar nicht um den Stolz, mir geht es darum, wirklich im täglichen aktiven Kontakt mit Patienten zu sein und wirklich eine solide Brücke für den beschwerlichen Patientenalltag bieten zu können und mit der Hilfe der Ärzte, mit der Hilfe der Industrie. Wir alle gemeinsam, wir können für Patienten etwas erreichen. Das ist meine Botschaft, meine Herzensbotschaft.
Nein, aber du hast völlig recht, wir haben das erlebt für die Hepatitis C und wir werden das dank dir in Schweiz erleben für andere Krankheiten. No, wirklich super. Herzlichen Dank, dass du hast.
Gerne.
So
und wenn
gut.
ich einen Arzt finden kann, der zum Beispiel bei uns mitmachen würde in der digitalen Sprechstunde, da bin ich würde ihn sehr herzlich gerne willkommen heißen.
Sehr schön. Wir werden das, werden wir sicher finden.
Danke. Danke, dass ich dabei sein durfte.
Vielen Dank. Danke dir, Karina. Danke. Jetzt we switch back to English. Now we are coming to one of the highlights of the life of the foundation, which is the prize, the annual prize of the foundation. This prize is named for Dr. Max Meyer. Dr. Max Meyer was in the board of the foundation. He has been really instrumental with us. It was fantastic to have his input, his insights, and also his support, because he's supporting this prize. And this is the reason why we named this prize the Max Meyer Prize. I hope he's with us online. I'm not sure, but really he has been a key person in the life of the foundation. And so thanks to him, we're able to support a young investigator in the field of NASH, coming actually from the industry part, but doing now master on NASH, looking at some aspect in detecting patients. So he's also going after patients identification, and I'm very happy that you, Dr. Petra Straha, is getting this prize. So you will present our project, and you will have to provide us after with a bank account so we can support you for this project, which is actually at the beginning. Thank you very much.
Many thanks, Professor Dufour. Super, super excited. And Karina, also many thanks for your fantastic presentation. I'm super energized by all your work, and yes, many thanks. So good afternoon. I'm super happy to be today your espresso, your I hope, a liver fibrosis protective espresso. And I would like to start with a question. What do you think in Switzerland, how many patients do we have at risk for advanced liver fibrosis? You do not know? We also do not know, and therefore we are super excited today to present to you the Inselspital FIP4 project. With we, I mean Professor Jean-François Dufour, Professor Annalisa Berzigotti, and myself, Petra Streicher. So the next question is it even important to have an answer on the question, on the previous question I asked? And we think, yes, definitely, because chronic liver diseases are a serious public health issue, and they are massively contributing to morbidity and mortality worldwide. So what are the causes in Europe for chronic liver diseases? The most prevalent one, or the most absolute driver, is NAFLD, with where we think that patients are up to 44% of the population is affected by NAFLD. Chronic Hep B and Hep C are less prevalent, but also important. What also Karina already said before, chronic liver diseases are massively underdiagnosed. So I said, today it's a problem, but will it be also in the future a problem? If we see that the prevalence of metabolic conditions like diabetes type B or obesity will increase in the future, yes, it will be an issue because NAFLD is closely related with metabolic conditions. And this translates that there will be a stress for the healthcare. We estimate, or there was a report, that by 2030, 1/3 of the Swiss population will be affected by NAFLD. That's an impressive number, I would say, and 6% by NASH. So NAFLD has a substantial economic burden, and I noted it down. There is an annual direct cost of around 45 billion for 52 million NAFLD patients estimated in the countries Germany, France, Italy, and UK. So a lot of money. But if you are looking at NASH, it is also very related with increased mortality, high clinical burden, patients' health-related quality of life burden, and to cite Antonovsky with his biopsychosocial model, it is also having a big impact on patients' social well-being. And therefore, the presentation or the work from Karina she presented with HEPA is super important. So what problem do we have in Switzerland? We have no approved pharmacological treatment for NAFLD, so there is no magic bullet for this disease, and it will stay important that patients are identified early as possible in their disease course, because then lifestyle changes, like for example Mediterranean food, more physical activity, and losing weight can have a positive impact on the disease course. And if you are doing something preventional, etc., you need data, and this one is missing. We do not have Swiss data on subject at risk for advanced liver fibrosis. So I said, what is the most important thing we are missing is the Swiss data. But additional, we're also missing that non-invasive scores, like for example FIP4, are automatically calculated at the lab report sheet. And for example, with a combination of recommendation, what the GP or the physician should do. We are missing also what Karina said before, at the disease awareness, also at the GP and specialist level. And a very important thing is also that the Federal Office of Public Health is not having NAFLD on the national health agenda. So I said a lot of problems and issues, but our team is quite solution-oriented. And what is our answer to one of the issues we are having in Switzerland? One is to close the knowledge gap. And this we want to do with the Inselspital FIP4 project, where we want to estimate the prevalence of adult subjects for risk at liver fibrosis in Switzerland based on the non-invasive score FIP4 score. So in a couple of next minutes, I will guide you through this project. First of all, who are we in this project? And the team, you see here the nice pictures. So we have Professor Berzigotti, who is the clinical director of visceral surgery and medicine in the Inselspital. We have Professor Dufour, clinic director, Centre de Maladies Digestives. We have Professor Nagler, Deputy Head of the Center for Laboratory Medicine in the Inselspital, and myself, Petra Streicher. I'm a master student from the University Basel, Bern, and Zurich, and this is part of my master thesis. Project aim, I said it already, prevalence estimation, and this for the first time in Switzerland. How do we want to do it? With a retrospective cross-sectional study based on the FIB-4 score from the patients from the University Hospital of Bern and year 2022. I will go in more details in the next couple of slides. I talked a lot of the FIB-4 score, but what is the FIB-4 score? It is a score where you can assess the liver fibrosis. And the beauty of this score is that it is inexpensive, simple, and globally validated. And on the upper right, you see also the score. It's based on very simple routinely assessed clinical parameters like the liver enzymes AST, ALT, platelet counts, and the age. It was also shown that it has a best diagnostic accuracy for advanced hepatic fibrosis compared to non-invasive clinical scores like the APRI or the NAFLD fibrosis score. And with the picture at the right, you can see that based on the FIB-4 score, you can stratify your patient population into 3 risk groups and based on 2 different cutoffs. So the first cutoff, the lower one, will guide you the patient and will stay in the primary care pathway. But patients at moderate or major risk, so they have a higher FIB-4 score, or should be referred to a hepatologist for in-depth investigation. So what is the objective of our project? I said estimation of the prevalence of adult subjects. This I said already quite often. But then additionally, we also want to do different comparisons. Like, for example, the risk factors associated with liver fibrosis between the different risk groups. But also we want to see the FIB scores, the distribution between the different clinics. So what is the project design? It is a retrospective cross-sectional study. This means we will get lab data from the laboratory. So everything is already analyzed, but we will get the data and we will calculate then the FIB-4 score. What data will be included in this anonymized data set? It will include at minimum 2,000 individual subjects. That's quite a lot, I would say. And we will target outpatient clinics from the University Hospital Bern and in the time frame of 2022. So what is the net benefit of this project? First of all, it is to close a knowledge gap. And this should then support further academic research activities. But also we want to inform this should inform then also the Federal Office of Public Health in the decision-making process. It would be fantastic also if the FIB-4 score could be implemented on the lab sheet, additionally with recommendation for the clinical care pathway at the GP level, but at the specialist level, and disease awareness. This altogether should support patients to be identified as early as possible in their disease discourse, where lifestyle changes can still have a positive impact on patients' life. And all together, so on the social level or society level, it should reduce the healthcare and economical burden, and on a patient level, it should have a positive health effect. So in summary, chronic liver diseases like NAFLD are a public health issue. I don't think we have to discuss on this bullet point. We all agree on it. We are missing Swiss data, but with the Inselspital FIB-4 project, we want to close this knowledge gap. It would be fantastic to have FIB-4 score calculated automatically at lab sheets, all together with clinical care pathway recommendation, which will also support the disease awareness. And this with the goal that patients are early as possible in this disease course identified, and then this should support to reduce the health and economical burden, but also support the patient's health. With this, I would like to thank you, the Swiss NASH Foundation, for the opportunity that we could today present this project, and also for the all the contribution and the support you are giving us, and also you, the audience, for this, for your attention. Many thanks.
Thank you very much. You presented very well your project. This is a very important project, and I'm very happy that actually the foundation is supporting you to realize this, because otherwise you don't have any other resource of to support it, and there are some costs involved into it, and you cannot apply to NIH or Swiss National Foundation or things like that for this kind of project. So it's difficult always to support them, and this is really one of the main tasks of the foundation, to identify excellent Swiss projects which can be supported and can take place. So it is really a good one. Now, so, we are used to have on our lab sheet EGFR, and nobody is afraid to look at the EGFR, knowing that it's based on some calculation for the kidney function. We should really reach this level in the liver diseases. As you mentioned, it's very surprising that we are not getting automatically the FIB4. There is a lot of publication validating the FIB4, highlighting also some shortcoming to this calculation, like age, for example. But still, this is so easy, so cheap, so easy to implement. It should be implemented, and I hope that your project will change that. They will convince, for example, the Inselspital to do it. They are not doing it, right, Petra?
That's right. So this would be fantastic if they could then implement it based on our project.
We have a question here in the chat. In the absence of Swiss data on individuals at risk for advanced hepatic fibrosis, how does chronic liver disease present a significant public health challenge?
Good question. So we are also looking at data from other countries, and something similar was also done in Spain, for example. And I cannot recall the data from the Barcelona cohort, but it was quite impressive how many patients were identified with an elevated risk of liver fibrosis. And as I said already, if we do not identify them early as possible, there is no pharmacological antifibrotic agent which you can give them. And you all know how difficult it is to implement or to convey patients to have a lifestyle change. So I hope this is answering your question. Otherwise, I think Professor Dufour will also have some comments on it.
No, I think you're right. I mean, with the FIB4, we are not only targeting patients with MASLD and steatotic liver disease. This is also validated in other liver diseases, and so I think we know that the majority of the patient will be in the context of a metabolic liver disease, but still, we also will be able to identify patients with abnormal FIB4, maybe advanced liver disease from other etiology. I mean, the liver, like always, the liver is not a painful organ, so you may destroy your liver without knowing it. And that we really, you really need to identify the patients early, as you mentioned, yes. But you will stratify the data, or at least you will have a granularity on the analysis of the data based on the different clinics, right?
Correct. And this will be also then interesting. Of course, some clinics will have more, or it's more prevalent to have high-risk patients, but maybe we also identify some clinics where we were not aware of it.
Yeah, that will be probably the case. Well, thank you very much, Petra. And again, I would like to really I extend my thanks to Dr. Max Meyer, who is supporting the foundation and supporting this prize. And I will give you his email address, and you can send him a note to thank him personally. And also we will let him know what's happened with the project. I'm sure it's in good hands with you. So thank you, Petra.
Many thanks, Professor Dufour.
Now we are moving to another topic, which is thyroid hormone receptors in steatotic liver disease. And I couldn't think of a better speaker than Professor Meena Bansal. She worked in Pennsylvania, and then she moved for more than 20 years ago in Mount Sinai in New York, where she's a director of translational research, working, you know, on both sides of the ocean, if we can say, of the medicine clinic and research. She published many, many papers in different areas, in hepatitis C, but also now in fatty liver disease. And she has a deep understanding of this thyroid hormone receptor in NASH. And it's a great pleasure to have you educating us on this topic, since this is probably one of the contender to be the first drug on the market. So thank you very much, Meena, to be with us today.
Oh, thank you so much. It's really an honor for being invited here to be part of the Swiss NASH Foundation presentation today. Congratulations, Petra. Absolutely important work, and we're doing similar things with screening our population. So I'm going to be talking about targeting thyroid hormone receptor in NASH. These are my disclosures. I'm going to start by talking about the role of lipotoxicity in driving MASLD or MASH, an overview of thyroid hormone signaling, specifically focusing on how it impacts lipotoxicity and mitochondrial function. I'll review some of the thyroid hormone receptor beta agonists currently under investigation, and then really focus on resmetirom phase 2 and 3 data, as Professor Dufour pointed out, is the kind of the leading agent in this class of drugs. So as many of us know, MASLD ranges from simple steatosis, which is defined as at least 5% fat in hepatocytes. And when that is coupled with lobular inflammation or ballooning with progressive stages of fibrosis, that is the progressive form of MASH that ultimately can lead to cirrhosis and hepatocellular carcinoma. And central to MASLD is dysregulated lipid metabolism. And this really comes from a convergence of a variety of factors, including genetic factors, environmental factors like our increasingly sedentary lifestyle and our high fructose diet, coupled with metabolic factors such as insulin resistance, type 2 diabetes, obesity, and dyslipidemia. This causes increased visceral adiposity and the increased delivery of free fatty acids to the liver from peripheral lipolysis. At the same time, there's increased fatty acids from the diet promoting de novo lipogenesis. Now, normally, the fate of these free fatty acids in the liver are to undergo mitochondrial beta oxidation or esterification to form triglycerides. But when the system is overwhelmed, this surplus of free fatty acids is now, the triglycerides is stored as lipid droplets and are partially released to the circulation as LDL. This results in the generation of lipotoxic lipid species. And when the system is overwhelmed, the metabolic capacity cannot keep up. There is failure of beta oxidation and mitochondrial dysfunction. This ultimately leads to the generation of reactive oxen species, causing cell injury, inflammation, and liver fibrosis. So the free fatty acid-induced lipotoxicity promotes endoplasmic reticular stress, oxidative stress, insulin resistance, and impaired autophagy. Autophagy is really a housekeeping mechanism of the cell, where the cell discards kind of tired organelles. And this is an important concept because the mitochondria in this disease are working very hard to oxidize these fatty acids, and therefore promoting their mitophagy is an important mechanistic pathway. Together, these free fatty acids activate apoptotic cascades, promoting tissue damage, inflammation, and these molecular events together contribute to the progression of NAFLD. Now, we're all familiar with common conditions that are associated with MASLD, such as obesity, type 2 diabetes, dyslipidemia, polycystic ovary syndrome, metabolic syndrome. But there are also a number of endocrinopathies that are associated with MASLD, such as hypogonadism, hypopituitarism, and the focus of our talk today, hypothyroidism. So the hypothalamus produces thyroid-releasing hormone, which then stimulates the pituitary to secrete TSH. TSH then works on the thyroid gland to produce thyroid hormone, prohormone T4, and the active hormone T3. Most of what we find circulating is the prohormone, or T4, and that is then converted in target tissues to T3. Low thyroid hormone levels, as represented by a low T4 and high TSH levels, causes symptoms of fatigue, weight gain, and feeling cold. Now, interestingly, population studies have shown associations between NAFLD and overt hypothyroidism, subclinical hypothyroidism, and even low thyroid hormone in the normal range. Patients with higher baseline TSH levels and no evidence of liver disease are more likely to develop NAFLD. Acute and chronic liver inflammation are associated with low intrahepatic thyroid hormone levels. And in fact, the top-ranked gene set downregulated in human fatty liver are T3 regulated genes. There are two primary isoforms of thyroid hormone receptors that mediate the physiologic effects of thyroid hormone. Thyroid hormone receptor alpha are predominant in the heart, brain, bone, and are responsible for the effects that you typically think of for thyrotoxicosis like arrhythmias or osteoporosis. Thyroid hormone beta is predominantly expressed in the liver, the kidney, and the pituitary gland, and are responsible for effects on metabolism. Importantly, they are crucial in activation of liver fat oxidation, which we will talk about in more detail. And importantly, the liver is the only organ where thyroid hormone receptor beta is expressed higher than thyroid hormone receptor alpha. Now, resistance to thyroid hormone is a syndrome of reduced hyporesponsiveness of target tissues to thyroid hormone. And patients who have this syndrome have increased liver fat compared to their unaffected family members, even when you control for BMI, insulin resistance, and environmental factors, as all of these family members live on the same small island in Portugal. So given the critical role of thyroid hormone signaling and thyroid hormone beta pathway in maintaining hepatic lipid homeostasis, how might thyroid hormone dysregulation play a role in NASH? Now, in the normal liver, the prohormone T4 is converted to the active T3 by the enzyme deiodinase 1, and small amounts are converted to the inactive form reverse T3 by DO3. However, in chronic liver injury, there is a downregulation of deiodinase 1 and upregulation of DIO3, such that there is an increased production of the inactive reverse T3, causing this relative intrahepatic thyroidism. So this local intrahepatic hypothyroidism observed during chronic liver injury is caused by depressed conversion of prohormone T4 to the active hormone T3, a decrease in the T3 to reverse T3 ratio, which is a marker of intrahepatic hypothyroidism, and downregulation of the hepatic thyroid hormone pathway. And this depressed thyroid hormone signaling in the liver sets up a vicious cycle, leading to additional inflammatory fat and hepatocyte injury. Now, importantly, if you treat patients with thyroxine or Synthroid, you actually have more exaggerated elevations of reverse T3 and reductions in the free T3 to reverse T3 ratio, because thyroid hormone receptor beta agonists, but not thyroxine, increase deiodinase 1 expression, therefore restoring or increasing the conversion towards the active form or T3. Now, there are a number of pathways that thyroid hormone beta agonists promote liver health. So there are genes that are upregulated by thyroid hormone beta receptor agonists, such as resmetirom. Those genes increase the uptake of free fatty acids from the circulation. They promote de novo lipogenesis. And importantly, they promote mitophagy, which, as I alluded to earlier, the mitochondria have been working on overtime. And so we want to really clear out those that are ready for retirement, and this pathway facilitates that. At the same time, it promotes mitochondrial biogenesis, or the replenishment of fresh mitochondria. So essentially, the fat-burning factory is ready to go, resulting in increased fatty acid oxidation. There's also impacts on cholesterol metabolism, and importantly, this pathway increases LDL receptor expression, and that is why you see decreased serum LDL levels from this class of drugs. Downstream, there are direct anti-inflammatory and anti-fibrotic effects. This pathway also upregulates a neutral protein called sex hormone binding globulin, or SHBG, which is a reflection of target engagement. And I'll come back to that in subsequent slides. So when we think about targeting intrahepatic hypothyroidism, we essentially have three goals of therapy. One, we want to, we want to have an effective treatment of MASLD by reducing intrahepatic lipid content, inflammation, and/or fibrosis. We want to be as liver specific as possible so that there's no effect on the hypothalamus pituitary thyroid axis. And lastly, we want to be beta selective so that we do not have side effects on the alpha organs, bone, osteoporosis, heart, in terms of rate and rhythm. Now, there are a number of completed phase 1 and early phase 2 studies. I'm going to go into more detail on MGL 3196 or resmetirom in subsequent slides. But briefly, phase 2A studies using the Viking 2809 drug looked at 42 patients with NAFLD and increased LDL, and they found an 18% reduction in LDL, coupled with a 60% reduction in liver fat and a decrease in AST and ALT. Turn 501 was looked at in a phase 1 study, 18 patients with elevated LDL, but they did not have NAFLD, or not known to have NAFLD. And they had demonstrated a 20% reduction in LDL. Now, ASC41 is being investigated in China, and in the phase 1 studies, they looked at in 36 patients with elevated LDL, again, not with NAFLD, and 20 patients who are overweight or obese with elevated LDL and not known NAFLD. There you see a robust decrease in LDL. Given the promising early results from ASC41, Turn 501, and the Viking drug, they have all moved forward in later phase 2A studies. I will go over resmetirom studies in a moment, but to highlight where we are with the other molecules, the phase 2B Voyage study uses the drug in patients with F2 and F3 fibrosis. The primary endpoint is at 12 weeks with a relative change in liver fat content as assessed by MRI-PDFF from baseline to week 12. And their key secondary endpoint is the histopathologic assessment at 52 weeks, looking for resolution of NASH without worsening of liver fibrosis. And I'm going to share data from the late breakers from AASLD in the subsequent slide showing the data from this 12 weeks. Similarly, Turn 501 is being looked at in the DUET study as a monotherapy and as dual therapy with Turn 101, which is an FXR agonist such as obeticholic acid. Here, the treatment population is presumed NASH on biopsy or imaging, and they have primary endpoint at 12 weeks with a relative change in baseline of MRI-PDFF. And again, I will share that data in a subsequent slide. ASC1 is being investigated in China as a phase 2 study, NASH on liver biopsy, including some patients with F1 fibrosis, but predominantly F2 and F3, and at-risk NASH as defined as an NAS score greater than or equal to 4, and their primary endpoint at 52 weeks is resolution of NASH or reduction in fibrosis by 1 stage without worsening of NASH. So this is the late-breaking data that was presented just a few weeks ago for the Viking study. This is the 12-week median relative change in liver fat. And as you can see, you start to see that you see a percent change of 48% from baseline at the 2.5 dose, and similar changes at the 5 and 10 milligram dose. About 85% of patients had a greater than 30% reduction in PDFF. And as you heard from Dr. Gomez earlier, this kind of 30% magic number of a decrease in MRI-PDFF has been associated with NASH resolution on biopsy at later time points. They also saw significant decreases in atherogenic lipids, including LDL, triglycerides, apolipoprotein A. Of note, they also saw similar reductions in fat in key subgroups, such as those with diabetes, and as well as both those with F2 and F3 fibrosis. In terms of top-line data that was presented at the liver meeting for Turn 501, it's being studied in combination with 101, as I mentioned, as the FXR agonist, but the data that was presented predominantly at the liver meeting was the monotherapy 501 versus placebo, with the primary endpoint at week 12. And what they saw, again, was this relative change in MRI-PDFF at 12 weeks, meeting the primary endpoint, both at the 3 milligram and 6 milligram dose. And you see that relative change in MRI-PDFF over time, starting at the 6-week time point, and then meeting the primary endpoint at 12 weeks at both the 3 milligram and 6 milligram dose. Now let's talk a little bit about resmetirom, MGL-3196, which is a thyroid hormone beta selective liver targeted molecule, once a day oral drug. And in their seminal phase 2b study, they looked at 125 patients. This was in the US at 18 sites. They included patients who had an NAS score of at least 4 with fibrosis stages of 1 to 3. They had to have at least 10% liver fat on MRI-PDFF. They included patients with diabetes who were on statin therapy, so really representative of a typical NASH population that we saw. Patients were randomized 2-to-1 resmetirom to placebo. The primary endpoint was the reduction in liver fat MRI-PDFF at 12 weeks, but then they also had a 36-week liver biopsy. And then patients who were on placebo were often offered crossover to open label therapy. So in terms of the primary endpoint, they saw that was met at 12 weeks. There was a dose-dependent 50% reduction of hepatic fat at the 80 milligram dose. They also met key secondary endpoints, which included a reduction and resolution of NASH on liver biopsy, a significant reduction in many fibrosis markers or NITs, statistically significant reduction in liver enzymes, and reduction in atherogenic lipids. The resmetirom responders with this 30% PDFF reduction at week 12 had higher rates of NASH resolution on the week 36 liver biopsy compared to non-responders, again suggesting that perhaps this early PDFF response could predict those who will later respond on liver biopsy. Now, the open label study, I think, was the open label crossover study was incredibly informative. So patients at 36 weeks were offered to go into open label study, and PDFF, which is a measure of fat fraction, as well as ProC3. Now, ProC3 is a molecule that reflects ongoing fibrogenesis. It represents the cleaved side of the N-terminal cleavage site of type 3 collagen. So it really reflects active fibrogenesis. And C3M is actually degradation of collagen, MMP9 mediated degradation. So the ratio of these two molecules can give you an idea of fibrogenesis versus fibrinolysis, and so therefore net fibrosis production. And so when you look at those who were on resmetirom for the entire time, which is reflected in orange, you can see the bar representing PDFF. You see a steady decline in PDFF over the course of the study. Similarly, you see this reduction in Pro-C3 over the course of the study, reflecting that you're decreasing fibrogenesis. If you look at the blue line, while patients were on placebo, there's really no effect. But then when they cross over to open label, you now see this steady decrease in both PDFF and Pro-C3. And similar results were seen by VCTE FibroScan. And when you look at that ratio of Pro-C3 to C3M, you see this kind of favorable decrease in net fibrosis formation. And now their registration trial, their phase 3 kind of top-line data, where the primary endpoint at 52 weeks was either NASH resolution without worsening of fibrosis or a greater than 1-stage improvement without worsening of NASH. You can see that they met both primary endpoints at the 80 milligram and 100 milligram dose. Similarly, there was a reduction, a dose-dependent reduction in LDL cholesterol. So this is the data that has been submitted to the FDA for early approval, and patients will continue to be followed for at least 5 years for the clinical outcomes. The FDA is expected to provide a decision on the approval of this drug March 14th, 2024, not this year. Unfortunately, I wish it already happened, but not quite. So we look forward to hearing about that in the next few months, and more to come. Now, the other interesting things, and I think one of the important things is with all of these clinical trials, is when you start to see everything moving in the same direction, your confidence for a positive effect is heightened. So in this was presented at EASL this year. You can see that those patients who were on 80 or 100 milligrams had steady reductions in both ALT and AST. Keep in mind, these are patients who had elevated ALT at baseline of greater than 30, as well as a decrease in GGT. And you see here this serum hormone binding globulin increasing with therapy, suggesting target engagement and therefore a predictor of biologic plausibility and potential efficacy. So how about being thyroid hormone beta selective? We want to make sure that all of these drugs do not have off-target effects and alpha effects. So far, there's no data reported for any change in heart rate from Turn 501 or the Viking drug, and the resmetirom has shown no changes in bone mineral density after 52 weeks of treatment, and no effect. Actually, they've now shared that there's no effect also on heart rate. So they seem to be quite thyroid hormone beta selective. So in summary, thyroid hormone-based treatment could potentially be beneficial in NAFLD by reducing intrahepatic lipid content, improving liver enzyme levels, inflammation, hepatocellular damage, and fibrosis. Current treatment strategies seem both liver-directed and beta-specific, limiting off-target effects and maximizing target effects. The thyroid hormone-responsive neutral protein SHBG may serve as a biomarker to monitor compliance and optimize dosing. And with that, I thank you very much and really appreciate the kind invitation to be here today with you.
Thank you very much, Professor Bansal, for this overview of the mechanism, of the details of how it's working, and also presenting the results of the different trials from the different companies. Thank you very much. I didn't know that, I didn't realize that, but you mentioned that when you engage the thyroid hormone receptor beta, you actually restore the activity of DO1?
Yeah, it's actually been in cell culture. Actually, when you treat in cell culture hepatocytes, you upregulate the expression of DIO1.
So you not only activate the right receptor in the organ which interests you, but also you restore the conversion of T4 in the
Correct. So
active T3.
That's correct. So this kind of, that's why thyroxine itself doesn't work. Obviously, you're worried about the off-target effects of thyroxine, but in addition, you haven't at all impacted this kind of DIO1, DIO3 ratio. So you're not really funneling more towards the active form. This is the theoretical hypothesis of how this is working. It's been shown in cell culture, and we know that DIO1 is decreased in chronic hepatic inflammation.
So meaning that's happened also in chronic hepatitis C and chronic hepatitis B.
You know, it's been shown really in NASH models, and in NASH, I don't know if it's been shown in hepatitis B or C.
Very good. Now I have a questions on this SHBP.
Yes.
So it's very good because there is here a marker who can tell us that the patient is taking the drug,
correct,
and
yeah.
that you have engagement, okay?
Yes.
But do we have any data that's actually predict response or outcome?
Yeah, so some of that data was presented. So if you have a greater than 120% increase in SHBG, that does predict biopsy response. That being said, if you don't have that, it doesn't mean that you don't have a response, but certainly if you have that greater than 120%, that's a predictor of response.
Yeah, that will be very important to have this predictor of response, as we will have maybe different drugs.
That's why I caution, though, that you wouldn't want to stop the drug if you didn't have that response, because it predicts, but it's not fully the story. So even patients who didn't meet that kind of threshold, they still could have a response. And so we don't want to say, well, if you don't have that, cut your losses, this drug is not going to work for you. But if you have that response, you're feeling very good about the fact that this patient is likely to have a histologic response.
And this drug is really, from a safety point of view, extremely safe.
Yes, I mean, the main side effects are GI related. It really didn't result in any discontinuation of drugs. They were all mild, moderate AEs, and they are gone within 3 months. So it's a very temporary kind of thing that if you just reassure patients, it resolves. So there's been no discontinuation because of any GI side effects.
Now, the phase 3 with resmetirom was positive. It was positive on both endpoints.
On both endpoints. So that's what I showed there, that both on NASH resolution without worsening of fibrosis and an improvement by 1 stage of fibrosis without worsening of NASH. So it hit on both endpoints, which I think is great. And I think the key is also that the other non-invasive assessments are all moving in the same direction. So when you start to see improvements in AST, ALT, improvements in liver stiffness, these are all things that increase your confidence that your effect is real. Moreover, 1 year is a short time in my mind as a fibrosis expert to expect to see reversal of fibrosis when we know this disease takes many, many years. So I think that it's great that we hit the endpoint at 1 year, but hopefully continuation in other patients will result in more patients having reversal of fibrosis as they continue on therapy.
Do you know what's the percentage of patients having achieved both endpoints?
It's on the same order. I actually had, I think that might have been presented perhaps at ASLD, but it's certainly on the, I don't want to misquote, but I think it's on the order of, again, that 20%, in that same range of 20-25% that had both endpoints.
Because this is very reassuring when you have a drug which, I mean, you achieve both endpoints globally in the trial, but also if you have a significant effect.
Yeah, I'm quite certain it's in that same kind of 20-25% range.
Wow, that's really effectively changed the field. So yeah, March 24, we all have to mark that in our calendar, right?
Yes, that's right. The Ides of March, I guess. The day.
Yeah, very good, very good. Okay, I asked a question, we were in the chat, so we are through. We are right in time, fantastic. Thank you very much, Dr. Bansal, for presenting this data and taking the time to be with us today. It was really fantastic. Thank you. So I will be the last speaker. Let me share my screen. There it is. Here we are. Can you see the screen? Is it okay? Wonderful. Okay. So I will not introduce myself. I will just try to minimize here. Well, wonderful. So I will present at the end of this day the FGF21 analogs to treat NASH. These are, I need to click here. Voilà. These are my disclosures. You will notice that the two companies which I will present results with their drugs are not present on these slides, which is good. This is the agenda of my presentation. I will introduce FGF21, talk about the FGF21 analogs, because they are not all created equal. I will present the results with pegozafermin, the results with efruxifermin, and say a word about the future. So FGF21, it all began with this GCI paper in 2005 by Alexei Karitonenkov, working at the Lilly Research Laboratories. And what he presented in this paper is that they identified a potent regulator of glucose uptake, FGF21, that FGF21 transgenic mice were viable and resistant to diet-induced obesity. The therapeutic administration of FGF21 reduced plasma glucose and triglyceride in OBOB and DBDB mice, models of obese mice, and that FGF21 did not induce mitogenicity, hypoglycemia, or weight gain. So, looks like a very attractive pathway. And now, less than 20 years later, we are getting there. So FGF21 is a stress hormone response. It's actually activated by many different kinds of stress. You see exercise here, which I think it's an important one, but you will see also different pathological stress, which may activate FGF21. But the half-life of FGF21 is very short, it's less than 2 hours. FGF21 is transducing its effect through a membrane receptor. There are different kinds of membrane receptors for FGF21 and another FGF, which is very important, which is FGF19. So we have FGF receptor 1, 2, 3, and 4. You will notice that the 4 is specific for FGF19. And the receptor as FGF receptor 4 is mainly expressed in the liver, and this is the feedback of the bile acid in the terminal ileum, leading to bile acid suppression, gallbladder filling, and hepatocyte proliferation. Here there is an effect, and so there was a drug here which was developed, aldafermin, which had the effect on the metabolism but didn't have the effect on the hepatocyte proliferation. It was tested in NASH, showed some effect, but was not further developed. Regarding FGF21, we have these different receptors. You will notice they all have a co-receptor with this beta-klotho. It's mainly the FGF receptor 1, which has a metabolic effect on weight loss, round fat thermogenesis, insulin sensitization, and reduce hepatic lipids. So let me show you a little bit how the effects are of FGF21. FGF21 has central nervous system effects, which mediate effects on the adipose tissues, but there's also direct effect of FGF21 on the adipose tissue, leading to increased thermogenesis, glucose uptake, increased lipid disposal, and an effect on lipolysis. There is also production of adiponectin, and adiponectin has many effects on the heart, on the vasculature, decreasing inflammation and atherosclerosis, on the muscle, increasing fatty acid oxidation, decreasing lipid accumulation, increasing insulin sensitivity. And here there is the effect on the liver, and the effect on the liver is mainly driven by adiponectin. You may have a direct effect of FGF21, but it is not sure. You will increase the fatty acid oxidation, decrease lipid accumulation, decrease VLDL uptake, decrease lipogenesis, increase insulin sensitivity, and also decrease oxidative and ER stress. So it's really a hormone which has effect which interests us. It has endogenous metabolic effects, regulating energy expenditure, glucose and lipid metabolism. It's reducing liver fat, but it has also an impact on liver fibrosis via this metabolic effect and effect on adiponectin. Interestingly, I would like you to share that with you, is that also mediate the effect on longevity, mediated by protein restriction. And it's known that protein restriction may increase longevity. So you have male, this has been done in male mice, you have wild type and FGF21 knockout on normal diet, on low protein diet. So now if you take the wild type control or the low protein diet, you say that if you have a low protein diet, you are living longer. And now if you do that in the FGF21 knockout, you reverse the effect. You are not only losing the effect, but they live shorter. So the effect, there is an effect of FGF21 on longevity. Now let's move on FGF21 analogs. So there are basically two ways to target this pathway. You can engineer human FGF21 analogs, or you may have FGF21 receptor agonists. Let's begin with the agonist. You may have, antibodies targeting the receptor, having an activation effect on the receptor, could bind to FGF receptor 1, could bind to beta-klotho, could bind to both of them. But what I will present today, these are FGF21 analogs. The problem with FGF21, as I mentioned, is the short half-life. So you would like to create an FGF21 which has a longer half-life. There are different ways to do that. You can pegylate the protein, has been done. We know that in hepatology for interferon, pegylated interferon, you can do that with FGF21, or you can create, bigger FGF21 with the Fc domain of antibodies. So there are different ways to do that, and we'll present two drugs which actually have been designed to have a longer half-life and to have a weekly administration. So I will begin with a pegozafermin. Now, pegozafermin, it's a pegylated FGF21. By pegylating the protein, you increase the protein size and hydrodynamic volume, reduce renal filtration, prevent degradation, so you prolong the half-life. You also protect antigenic sites, so you reduce immunogenicity, and because you have steric repulsion between the pegylated surfaces, you have a very stable formulation. There are also some mutation. You have mutation at position 173, which is prevent cleavage of the protein, and so you have a longer half-life. The glycopegylation technology allows a site-specific linkage, and so you retain the potency of the FGF21 against the receptor, and you have a flexible glycosyl bond which help the glycopeg moiety to remain intact, and so you have quite a long half-life. So if you look at this pegozafermin, it looks like that. You have the glycopeg here, you have some mutations, and you have a half-life from 55 to 100 hours, which is much longer than the less than 2 hours of the native FGF21. It's still engaging the FGF receptor and the beta-gluto in the nanomolar potency domain range. It has, that's important, no activity on the FGF receptor 4 that can lead to an increase in LDL levels, and also we have some mitogenic effects. So there was a study shortly published, randomized controlled trial of FGF21 analog pegozafermin in patients with non-alcoholic steatohepatitis. As you can see, it was in the New England. It's a phase 2b, double-blind, randomized placebo-controlled study performed only in the US, lasting for 24 weeks in patients with biopsy-confirmed NASH at the stage of fibrosis F2 and F3. They stratified the inclusion for type 2 diabetes and F2, F3 degree of fibrosis, and they administer pegozafermin subcutaneously, 15 mg each week, 30 mg each week, or 44 mg every second week. They had two primary endpoints based on the analysis of the slides by 3 pathologists blinded to the patients, to the treatment, and also to the sequence of treatments, if it's the beginning or the end of the study. So the 2 primary endpoints, no surprise, improvement of at least 1 stage of fibrosis with no worsening of NASH, and NASH resolution without worsening of fibrosis. So this is the result on the fibrosis improvement. So you see the number of patients included, 61, 14, 66, and 51. So it's not a very large study. It's a phase 2b trial. In the placebo, we have 7% with fibrosis improvement without worsening of NASH. And you have 22%, 26% in this arm with most of the patients, and 27 in the every second week administration, which was significant. So you have an effect on the fibrosis. Now looking at NASH resolution without worsening of fibrosis. This happened in only 2% in the placebo group. In the 15 milligram every week, you have a 37, but here you have a low number of patients with only 14, so you will change a few patients, you will change this percentage. Which is most important is to look at the 30 milligram and 44 milligram, and you have 23 and 26. Here you have also an effect on the NASH resolution without worsening of fibrosis. Regarding the other endpoints of the study, you had improvement in the transaminases, particularly in the alanine aminotransferase. You had a decrease in the liver fat. In the 30 milligram, you see by 48%. And they also had liver stiffness, and you had an improvement of liver stiffness in kilopascal by 3 in this group, which is quite a lot. And you have an effect on the triglyceride. I mean, this is one of the strong effects of FGF21 on the triglyceride. And you also had an effect, modest, but you had effect on glycated hemoglobin. So all the different parameters are moving in the good direction. Let's look at the safety of this drug. So any side effects, 68% in the placebo group, 85% in the 30 milligram weekly. Side effect is about the same percentage, and side effects related to placebo pegozafermin, you see 29% and 54% here. What are the side effects? Here also, mostly GI. We heard that for the dual agonist. We heard that for resmetirom. It looks like all these drugs targeting NASH will have mostly GI side effect. We have nausea, we have diarrhea. Of course, because you have to inject the drug, you may have erythema at the injection site, which is interesting in that you have an increased appetite, but they reported that there was no change in the body weight of their patients participating in this study. This is the results with pegozafermin. Let's look at the results with efruxifermin. First, let's look at what is efruxifermin. So it's not a pegylated FGF21. This is actually a molecule with two FGF21 linked to the Fc component of the antibody, and there's a linker here. So you have two molecules of FGF21 in efruxifermin. So there's three different mutations, one to prevent aggregation, one to protect against loss of beta-carothol affinity in vivo, and one to increase beta-carothol binding and improving in vivo stability. So you mimic the biological effect of FGF21. You have a half-life in 3 to 4 days, and you have a balanced potency for FGF receptor 1, 2, and 3, not on the 4. Now, this is the study. This is a phase 2b study, which was also published recently, the Harmony trial, with Stephen Harrison as the first author. This is also a phase 2b double-blind, randomized, placebo-controlled, also performed only in the US. It's a 96 weeks study, but they presented the analysis on baselines and week 24 in biopsied patients. Inclusions is biopsy-confirmed NASH with the F2 and F3 stage, and they had a placebo group and two groups with efruxifermin, 28 milligram and 50 milligram each week. They had here one primary endpoint, which was the improvement of at least one stage of fibrosis with no worsening of NASH. The improvement of NASH without worsening of fibrosis was the secondary endpoint. So if you look at the primary endpoint, you see here the three groups. You see first that in this study, the placebo effect is much larger than the previous one. It's always a subject of discussion in the field of NASH and NASH trials, how different are the effects in the placebo group, and sometimes quite important in these studies. So we have a fibrosis improvement for at least one stage at week 24 is 20% of the patients in the placebo group, 41 patients, 39% in the efruxifermin 28 milligram, but we have 38 patients, and we have 34 patients in the 50 milligram with 41%. So it is quite significant. It's a phase 2b study, so the numbers are not very large, but it's clearly an effect, which seems also to be a little bit higher in the higher dose. Regarding the key secondary endpoint, which would be a NASH resolution without worsening of fibrosis at week 24, in the placebo group we have 15%, and here we have 47% in the efruxifermin 28 milligram, and in the 50 milligram it's going to 76%. Sorry, I'm going too fast. So quite a clear effect on the NASH resolution. So you have an effect on the fibrosis, you have effect on the NASH resolution. So one of the questions that there was a question I was asking regarding esmetirom is the percentage of patients where they have both endpoints. So here we have 5% in the placebo group of patients achieving fibrosis improvement and NASH resolution at week 24, but it is much higher in the efruxifermin group 28 milligrams, 29%. It's even going to 41% in the efruxifermin 50 milligrams. So here you have really an important effect in comparison to the placebo, and you have a substantial fraction of patients achieving both endpoints after 24 weeks. It is quite impressive. If they look even at the fibrosis improvement by more or equal with 2 stages, the numbers are smaller, but still from 5% to 16 and 15%. So they have patients really having an improvement in the fibrosis degree with these drugs and also achieving NASH resolution. Side effects, so any TAEs with an incidence more than 10%, you see placebo is 49%. Here we have 73 and 79%. But again, it's mostly GI side effects. You have diarrhea, 19% and 40%, nausea, 23%, yes, 28 and 42%, erythema, and also increased appetite. 20% and 23%, but here also they presented the data for body weight. It was not significantly increasing with this drug. So now we have 2 drugs in phase 2b with quite attractive results. So what will be the future? So Professor Romero-Gomez presented dual agonist of GLP-1 with GIP or glucagon receptor. I think it's very interesting to see that there is a molecule which is a dual agonist, FGF21 and GLP-1, a dual agonist. So you have on one side GLP-1, you have the IgG4-Fc domain, and you have on the other side with the linker the FGF21. So you really have here a molecules targeting GLP-1 receptor and FGF21 receptor. So this is just a description in this paper of these molecules. They have few data on the biological effect. There was one on the accumulation of food intake. I was telling you that FGF21 increase appetite. So if you combine the drug and you have the GLP-1, at one point you have you lose this effect on the increase of food intake. So I think this is a highly interesting, and with hope we'll see more data with such kind of approach. So what are the take-home messages? Is that FGF21 is a very important pathway as an attractive target to treat NASH. Several analogs have shown efficacy, show impressive effect of both drugs on the fibrosis. There was also data with efruxifermin in cirrhotic patients in the Symmetry trial showing an effect. So this is probably drugs we can use in advanced NASH in terms of fibrosis. They have a good safety profile with GI side effects that other drugs use in NASH. Obviously, we have to see data from larger trials in phase 3 trials, and also a combination, and so maybe drugs with a dual effect as I presented. This said, I am arriving at the end of my presentation. I will stop to share my screen and see if I have any questions. I do in the chat. How does FGF21 influence glucose metabolism? So it's an insulin sensitizer. It has been identifying as actually stimulating glucose uptake in cells in the 2005 paper. And if you look in the trials I presented regarding glycated hemoglobin, you have an effect, a small effect, but decreasing glycated hemoglobin. So it's not a large effect on the glucose metabolism, but it's an effect going in the good direction. I have a second question. Why is it crucial that pegozafermin has no activity against FGF receptor 4? On what potential consequences could arise from increased LDL levels associated with FGF receptor 4 activation? Yes, FGF receptor 4 is the target for the receptor. FGF receptor 4 is a target for FGF19 in human, 15 in rodents. This is the hormone informing from the ileum that the bile acid reached the ileum, and so we are in the late postprandial phase, and so it will loop back to the liver, which will have an effect on the metabolism. So that was the reason that drugs have been developed to target this pathway, because it will activate also FGFR receptor. But FGF receptor 4 has an activity on the replication of hepatocytes. It also has an effect on the metabolism of the cholesterol, which is not the effect you would like to have on the cholesterol, because you will increase the LDL cholesterol. So this is something you want to avoid. And so this is the reason aldafermin had not mitogenic effect, but still was targeting FGF receptor 4. It's better to have an effect on the FGF receptor 1, 2, and 3, where you don't have this effect, this negative effect, negative metabolic effect, or possibly mitogenic effect in the liver. So that's the reason it's important when they develop this FGF21 analog to have specific effect on receptor 1, 2, and 3, which is also the receptor for FGF21. You notice that FGF21 has no effect on the FGF receptor 4. I hope I answered this question. And I don't have any other question in the chat. So that's bring me to the end of this symposium. I would like to express my sincere thanks to the speakers who prepared fantastic presentations. We have seen how 2023 was an important year in the field of NASH, with a new nomenclature allowing to better identify and better study patients with MET-ILD. We have new drugs which are very promising. 24 might be the year we have an approved drugs to treat NASH. I would like also to thank our sponsor, Madrigal and AstraZeneca. It would not have been possible to have this symposium without their support. Again, I would like to thank Dr. Max Meyer for supporting the prize. Really, really generous from his part. And I would like to thank Healthbook for organizing it so well. The technique was, from my side, excellent. Now, if you want to have your credits, I think there is really a link when you can do this, is what Healthbook told me. This said, many thanks. I wish you a good end of the day, good evening in Europe, and good afternoon in US. Thank you very much to all.